Everything is good to go. So I welcome you all for today's session. A very good evening to all of you. I am Dr. Priyanka Sachdev here. So if I'm clearly visible, audible, can you write down in the comment box? If everything is good to go, I will start the session ahead. Still I cannot see it. Wait a while. I guess everything is good to go. Yes, it has started. Thank you so much. Thank you for confirming. So I welcome you all for today's session. A very, very good evening to all of you. I am Dr. Priyanka Sachdev here, and today we all are gathered here to do the rapid revision of entire community medicine. So whatever exam you are targeting for, the medical entrance exam, maybe you are targeting most of your FMG, or maybe you are targeting the next upcoming NEET PG. So this is a compact revision of the community medicine, and that will help you in cracking the question of the community medicine. So whatever exam you are targeting, you get many questions from this subject. Okay, so we will revise it. Very quickly. Yes, so can we start? So let's start it. Without wasting any further time, let's start it. It's a compact revision, rapid revision of entire community medicine in one shot. Okay, let's start it. So let's start. We will go chapter by chapter, the important topics, the important points. The first chapter, the first topic, I am starting the concept of health and disease. So let's start it. So here I would like to teach you 5-6 topics. This chapter is very important, and very frequently you get at least 2 to 3 MCQs from this chapter every year. Okay, so let's start it. First of all, the definition of the health. WHO definition of the health, you have to learn it. So WHO has given the definition of the health in 1948. It is having 3 components in it. So health is the state of complete physical, mental, and social well-being. You can learn the mnemonic. The mnemonic is PSM: physical, social, and mental well-being. So health is the state of physical, health is the state of mental, and health is a state of social well-being. You can learn the mnemonic. Health is a state of PSM. Health is a state of PSM. This is the definition given by the WHO, not merely the absence of the disease. So WHO says that health is not merely absence of disease. It is the complete state, complete physical, mental, and social well-being. Then we can say the person is healthy. The person, and it's a dynamic, it's not a static state, it's a dynamic state. Health keep on changing every fraction of second. So that is the definition of health. Please learn the mnemonic PSM for that. You can get an MCQ that which of the following is not a component of health in the WHO definition of health. So 3 options will be this, that is physical well-being, social well-being, mental well-being, and the 4th option can be anything else. So you can easily pick that up if you know the definition of the health. This is WHO definition of the health. Okay, now coming on the dimensions of the health. But how many dimensions of health there are? There are many dimensions of the health. Okay, there are 10 dimensions of health. In the definition, there are only 3 components, but the dimensions are 10 dimensions. So there is a mnemonic to learn. The mnemonic is PSM essence. PSM is same. So P for physical, S for social, M for mental, the same 3 which were there in the definition. But apart from PSM, extra is essence. You have to learn these are the dimensions of the health. So E, double S, E, and CE. So there are 2 E. One is emotional, one is environmental. There should be emotional well-being, environmental well-being. There are 2 S. One is spiritual, one is socio-economic. One N, nutritional, C is cultural, and one more E is educational. So please learn these are the dimensions of the health. So if somebody asks you the definition of the health, only 3 component PSM. If somebody asks you the dimensions of the health, there are 10 components. The mnemonic is PSM essence. So you can easily pick up the MCQs. The MCQs are very simple. Which of the following is a dimension of health, or which of the following is not a dimension of health? You should be easily able to recognize it if you know them. Okay, now coming on the standard of living. So what is the standard of living? What is your standard of living? What is my standard of living? Each one of us is having different standard of living. Actually, the standard of living depends on the geographical area we belong to. Usually we compare the standard of living from country to country. So standard of living is different in India. The standard of living is different in Canada. The different standard of living is different in US. So the people living in a particular geographical area, this is a geographical area, this is a geographical area, this is country A, country B, 2 different geographical area. So the people residing here and the people residing here may have different standard of living. So what is the criteria? How we can judge the standard of living and compare the standard of living? So basically the standard of living depends on 3 things according to WHO. What is standard of living? It refers to the scale of expenditure how much expenditure the person can do. Number two, how much goods the person can consume, and how much services the person can enjoy. Based on these three things, we decide the standard of living of that particular person. Okay. Now it depends on three things. Number one, income and occupation. We take them together because whatever is the occupation, that's going to decide the income of the person. So income and occupation taken together. Okay. Occupation is only going to decide the income now. So income and occupation decides the standard of living. Number two, house, sanitation and nutrition. We take it together. So person is living in kacha house or pakka house. Sanitation is it good sanitation or poor sanitation? Nutrition, whether the person is taking adequate calorie per day or not calorie per day, like that. So house, sanitation and nutrition, roti, kapda, makan, we take them together. And number three, level of provision of the health, education and recreation. We take them together. These three things decide the standard of living. Till now, I taught you three things. WHO definition, learn the components, the three components PSM, the dimensions of the health, learn the components, there are 10 components, PSM essence, we will repeat, and standard of living, learn the components of standard of living. Okay, so you get the question, which of the following is not a component of standard of living? So these things are very confusing, you get confused, they all are related, they look like related, actually these are different. So standard of living depends on money. The person is who having more income is having good standard of living. The person is not having good income, it doesn't have good standard of living. So it is depending per capita GNP. Please remember, standard of living depends on money. It depends on income. It depends on per capita GNP. Okay. The next is the socio-economic indicators. Sometimes you get question on the socio-economic indicators. We will see the indicators all together. You can leave it here. So till now what we have learned, we will revise it. The WHO definition of health. WHO definition of health. What are the components? Dimensions of health. Dimensions of health. What are the components? And standard of living. Standard of living. What are the components? The three things I take together intentionally because they look similar. And you get MCQs on them to pick them, which of the following or which of not the following. So if you read them together, you can easily discriminate them. So WHO definition of health have only three components. PSM. Physical, mental and social well-being. That's it. Not merely the absence of disease. The dimensions of health have 10 components. One is PSM. The three of them are PSM. Apart from that, 7 more are there. That is essence. Essence. It's like this. Essence. You have to learn essence. Okay. You should know the full form of that. And standard of living have only 3 components. What are the 3 components? Number 1, income and occupation. Number 2, roti, kapda, makan, nutrition, housing, and sanitation. And sanitation, not clothing, it's sanitation. And number 3, the provision to health, provision to education, and provision of recreation. So these are the 3 components of standard of living. You get simple MCQs on that. Okay, yes. So coming on the next thing, quality of life. Who decides the quality of life? What are the various components that decide the quality of life? Or what are the various socio-economic indicators for the quality of the life? So there are 4 indicators, and every year, almost every year, whether it's a NEET, PG or FMG, you get question on that. Almost. It's a very high yielding topic. Very frequently, I must say, you get question on that. You can't skip this portion. So there are four different components, or you can say the criteria for deciding quality of life. We will discuss them in detail. The first is PQLI. What is the full form of PQLI? Physical Quality of Life Index. Physical Quality of Life Index, PQLI. The second is HDI, Human Developmental Index. Human Developmental Index, HDI. The third is complementary to that, Human Poverty Index. This one was Human Developmental Index. Now Human Poverty Index, HPI. And the last one is Multi-Dimensional Poverty Index. Multi-Dimensional Poverty Index. Nowadays we have replaced HPI with MDPI. So we will study these 4 one by one, and we will make a comparative table between them. You frequently get question on them. Please, people, don't skip it. Please concentrate. So coming on, PQLI. First of all, PQLI. One by one, we will take it. So PQLI. What is the full form of PQLI? PQLI is Physical Quality of Life Index, PQLI. So let's take PQLI and HDI together. First, compare them. The first 2 I am taking together. Here you can see. So here we are comparing the first 2. PQLI, Physical Quality of Life Index, and Human Developmental Index, HDI. PQLI and HDI. Okay, now here we will see 3 things. We have to take 3 criteria. We have to take the longevity, we have to take the knowledge, and we have to take the standard of living. So we have to take three dimensions. 3 dimensions. So we have to take one criteria under each dimension. Okay, so for longevity, what we have to say in PQLI, what we are taking the longevity. Suppose for example, please understand, there is a geographical area A and geographical area B. Suppose these are two countries. For example, this is country India and this is country US, or this is country Japan, any two countries. So people living here have a quality of life. People living here have a quality of life. How to compare the quality of life? Which people is having better quality of life? There should be some objective criteria to compare them. So I can compare the PQLI. I can calculate the PQLI here and I can calculate the PQLI here, and then I can decide which group, which geographical area people is having better quality of life. Or I can compare the HDI. I can calculate here HDI, and then I can do the comparison. So these are the things which we can compare in two different geographical area. So let's start with the PQLI. So in PQLI as well as in HDI, we have to see three dimensions in each of the country, in each of the geographical area. What are the three dimensions? We have to look for the longevity, knowledge, and standard of living. Okay. For longevity in PQLI, we see life expectancy at the age of 1 year. At the age of 1 year, when the age is 1 year, that is infancy. At the first birthday, we see the life expectancy. I will explain. So these are the two countries, as I told you. This is country A, country B. Geographical area A, geographical area B. Here a newborn is born today. Here also a newborn is born today. And this is the first birthday of the newborn. The newborn becomes 1 year old. This is also the first birthday of the newborn. The newborn becomes 1 year old. Now, applying the mortality and morbidity indicators of this country and this country on this newborn, on this infant, what is the life expectancy of this infant? What we are expecting, that this infant will survive for how many years? We are expecting, it's not a reality. We are expecting that if the infant is going to survive in India only, the infant will survive for 70 years. Now, if this is an infant in Japan, this infant is surviving in Japan only, so it will survive for 8 years. It's an expectancy. The reality can be anything. So that is life expectancy at the age of 1. At the age of 1, at the first birthday, we are taking life expectancy at the age of 1 in PQLI. But in HDI, we are taking life expectancy at birth itself. Life expectancy. The newborn is born. As soon as the newborn is born, the moment the newborn is born, what is the expectancy? This newborn is going to survive for how many years? If it is going to survive in India, if it is going to survive in US, if it is going to survive in Japan, it is going to survive in this particular country. So what is the life expectancy? Different countries have different life expectancy. So here we are taking life expectancy at the age of 1 year, and here we are taking life expectancy at birth. Please learn. Okay, now coming on the knowledge, we have to see the knowledge. Okay, now this is country A, this is country B. I want to see the knowledge of entire country, not one individual. What is the knowledge of this country? All the people residing here. How can I calculate the knowledge? How can I calculate the knowledge here? Knowledge here and knowledge here. How to compare the knowledge between two countries? How? Entire country, entire community, geographical area, not one individual. So for PQLI, we will calculate the literacy rate. What is literacy rate? And we will compare the literacy rate of the two countries. What is literacy rate? Who is a literate? Who is a literate in the entire country? Who is the literate? Any person who can read, who can write, and who can understand at least one language. All three things. Some people are there who can read but cannot write. They are illiterate. Some, they can write but they cannot understand that. They can read, they can write, but they cannot understand the meaning. No, they are illiterate. So at least one language may the person can read, the person can write, and the person can understand at least one language. That person is known as literate person. That person is known as literate person. Okay, now this definition is applicable for more than 7 years of age. Now I'm having a kid. My kid is 3 years old. Okay, my kid cannot read, write, and understand at least one language. So I cannot say my kid is illiterate. I will say my kid is learning. I cannot say it's illiterate. He will be literate. Okay, but it's learning stage. No, he has not even learned one language because he's a kid. So up to 7 years of age, we don't include the population here. We exclude the population up to 7 years because up to 7 years, we consider it's a learning age. But after 7 years, if someone cannot read, write, and understand even one language, that person is totally illiterate. Okay, so in this country, how many people are literate? That is the literacy rate. In this country, how many people are literate? That is the literacy rate. Compare the literacy rate. So by comparing the literacy rate, you can compare the knowledge of the two countries. So here we are taking literacy rate. In PQLI, we are taking life expectancy at the age of 1 for seeing the longevity, and we are seeing the literacy rate. But in HDI, we don't take literacy rate. We see the years of schooling. Years of schooling. Okay, years of schooling. So schooling doesn't mean only schooling. Okay, so how many years of schooling average a person goes? initially we do nursery, KG1, pre-KG, KG junior, KG junior. So, KG1, KG2 like that. Okay, so 3 years of this. After that, standard 1 to standard 12. Class 1, class 2, class 3, up to 12 standard we study. So 12 years is this. After that, at least for bachelor degree, 3 years. I'm not talking about the MBBS student. So at least 3 years for the bachelor. So 12, 13, 14, 15, 16, 17, 18. So nearly 17 to 18 years on an average, a person goes to school. By school, I mean the complete schooling, including the college also. So it is expected for how many years the person is going to the school. Okay, so here we take the mean year of schooling plus expected year of schooling upon 2, and that will reflect the knowledge of that country. So for example, this is the country, I want to know the knowledge of this country. So this country is having people in that. Okay, so what is the mean year of schooling? Mean year of schooling of all the people here. Okay, some people go school even more than 18 years, like the MBBS, like the doctors, like the medico, they study for many years, Hana. And some people even don't go to school at all. So mean year of schooling plus expected year of schooling upon 2. I calculate this and this will reflect the knowledge of this country. So for knowledge, we are not using literacy rate here in HDI. We are using years of schooling, mean year of schooling plus expected year of schooling upon 2, the average of that. And that reflect the knowledge. For knowledge, we are using different things. Okay, so first we have compared the longevity, then we have seen the knowledge, and finally I'm looking at the standard of living. For standard of living, PQLI people have taken infant mortality rate. How many infants are dying in that country? Who is an infant? A newborn, a child who is less than 1 year of age, that is an infant. So if more infants, suppose there are 2 countries, in one country infant mortality rate is very high and in another country infant mortality rate is low. We compare the infant mortality rate in 2 countries, country A and country B. Suppose here infant mortality rate is high and suppose here is low. What does it reflect? It reflects that in this country the health services are not very good. The doctors are not good, the hospitals are not good, health services are not good. That's why infants are dying more. And this reflects here the health services are very good because this is a very fragile group. Infancy is a very fragile group. That's why we are seeing the mortality in that age group. So if mortality is less, it means the health services are good in that country. And if mortality is high, it means the health services are not good in that country. So that reflects the standard of living of the 2 countries. So for standard of living, we are comparing the infant mortality rate of the 2 countries. So PQLI people believe that here the 3 components do not include money. But HDI people believe that income is necessary. For a good quality of life, good income should be there. So if the real GDP is high, the quality of life will be good. If the real GDP is low, the quality of life will be less. So HDI people believe that money decides the quality of life. And PQLI people believe that money is not everything. Even without money or less money, people can have a better quality of life. Both are different groups. Okay, we have to compare the three things. So what is the standard of living here we are taking as a criteria and what here we are taking? Got my point? So can we compare? Okay, so we will see the three criteria of PQLI, that is physical quality of life index, and HDI, human developmental index, HDI. Now tell me how we compare the longevity in each of them. Tell me how we compare the knowledge in each of them. What is the criteria for knowledge? And what is the criteria for standard of living in each of them? I taught you very clearly. So in PQLI, for longevity, we take life expectancy at the age of 1. And here we take life expectancy at birth. Why it is like so, I will tell you. In a fraction of moment, I will tell you. Okay, wait a while. For knowledge, here we take literacy rate. Who's a literate? A person who can read, who can write, and who can understand at least one language more than 7 years. That is a literate. So in a country, how many people are literate? That will decide the knowledge of that country. In India, how many % people are literate? In US, how many are literate? In India also, if you calculate state-wise, in Maharashtra, in Kerala, in Madhya Pradesh, in Uttar Pradesh, in Andhra Pradesh, in Tamil Nadu, so you will get different literacy rate. State-wise, highest literacy rate is in Kerala. You may be knowing that. I will give you all the details. Okay. And here, for knowledge, we take years of schooling. Okay. So mean year of schooling plus expected year of schooling upon 2. So this reflects the knowledge. In HDI, for knowledge, we are using like that. We use the years of schooling. We don't see the literacy rate. We see average in that country for how many years people go to school. That will reflect the knowledge of that country. So both the things are right at their own place. Either you see how this is a country, how many people are literate in that country. That will reflect the knowledge of that country. Or else you see in this country how many years people go to school on an average. That will reflect the knowledge of that country. So both the things are correct. And the third thing, for standard of living, PQLI don't believe in money. They see infant mortality rate. They have given priority to the health, not to the money. So the country which is having high infant mortality rate, that is having poor doctors, poor healthcare services. I mean, the doctors are not good, the hospitals are not. That's why infants are dying more. So that country doesn't have a good quality of life. And the country which is having a low infant mortality rate, that country is having good healthcare services. So infant mortality rate will decide the quality of life, the standard of living. You got my point? Here, these people believe that money, income, real GDP per capita. So the country which is having more income, the people living there will have good quality of life. And the country which is having less money, people living there will have not good quality of life. They believe in money. So the third. So because here, now please listen, because here we are taking infant mortality rate. What is infant? The death up to 1 year of age. Any death which is occurring up to 1 year of age. So that's why we are taking life expectancy at the age of 1. You got my point? Because up to 1 year, 0 to 1 already we have included in infant mortality rate. That's why we are not taking life expectancy at birth. We are taking life expectancy at the age of 1 because we have already taken infant mortality rate. But here we are not taking infant mortality rate. That's why we are taking life expectancy at birth. I have given the reason also. Okay, maybe the session up to the next 3 hours, 3 to 4 hours. I'm not very sure. Okay, till I can deliver, I will keep continuing. Okay, can we go ahead? Okay, so please see. So please compare the 3 criteria here without any confusion. So you get the options. Which of the following is a component of PQLI or HDI, or which of the following is not a component of PQLI or HDI. So you should know these 3 very clearly, without any confusion, any fogging in your mind. It should be crystal clear concept. Anyone have any confusion? Give me a thumbs up otherwise. Can I go ahead? You got the 2 things. So what are the 3 component of PQLI? What are the 3 component of HDI? You got it? How we measure? What is the range of PQLI? We measure PQLI from 0 to 100. 0 means worst quality of life. 100 means best quality of life. So where does India lie? India is above average. Average is 50%. India is on 65. India is on 65. It's above average. So in India, let's talk about India. In India, the quality of life is above average, we can say. It's 65. The current, it's keep on changing, but currently it's 65. Okay. And here the range is 0 to +1. It's not 100. So again, the 0 is the worst. And here +1 is the best. So again, India is 0.64. It's more or less equal to 65. 0.64. So here the value for India is 0.64. That you have to learn. Can we go ahead? So that too we have done. So I want to teach you 4 indicators for quality of life, out of which we have completed 2 yet. 2 more to go. So total 4 will be done, and then we will compare all 4 together. Yes, this is a very confusing topic, but it will be super easy. It will be cakewalk for you. So we have done PQLI, you know the 3 components. We have done with HDI, you know the 3 components. First we will finish it. Then we will come on HPI and MDPI. After that we will come. So I will give you the details of these 2. Let's start the first one, PQLI. I already explained you PQLI. What are the 3 components of PQLI? For longevity, we take life expectancy at the age of 1, not birth. For knowledge, we are taking literacy rate, not years of schooling. And for standard of living, we are taking infant mortality rate. We are not taking income. So income is not a criteria here. Please learn, because the 4th option is always income. The question is very frequently asked, which of the following is not a component of PQLI? 3 options are these. The 4th one will be income, GDP, GNP per capita. So you have to pick that up because they are not considering income as a criteria. Okay, these are the 3. It is from 0 to 100. 0 means worst, 100 means best. And for India, the value is 65. And it is not taking income in consideration because PQLI people believe money is not everything. Even with less money, people can have good quality of life. What do you believe? Even with less money, people can have good quality of life? You believe in PQLI or HDI? You believe that for a good quality of life, money is required, or even without money or less money, people can have good quality of life? What is your thinking? Both are different bodies. Okay, and both are correct. None of them is true. None of them is false. Both of them are equally correct. But the criteria are different. For judging quality of life, we are using different criteria. That is the thing. Okay, chalo. So that is the thing. Okay, so we are done with PQLI. Now HDI. I have already explained you HDI. What are the three criteria of HDI? For longevity, we take life expectancy at birth. Life expectancy at birth. Okay, either write like this or write like 0. 0 means birth. For knowledge, we don't say literacy rate. We see the years of schooling. The mean years of schooling and expected years of schooling divided by 2. And the third criteria for standard of living, we use income. We don't use infant mortality rate. And here it is 0 to +1. The 0 is the worst, +1 is the best. And India ranking is 0.64. I already taught you. So we are done with 2. Can I come on the third one? We are done with PQLI. We are done with HDI. Now I'm starting the third one, HPI. HPI and followed by the last one, MDPI. So what is HPI? What is HDI? It is opposite of that. What is HDI? First you understand HDI. Human, D for developmental, human developmental index. So this is human poverty index. Okay, so it is opposite. You can say it is complementary of HDI. So HPI is complementary. HPI, human poverty index, is complementary of HDI. What do you mean by that? Can you see this image? What's that? Can you write down in the comment box what you can see in this image? Now, some students say, ma'am, glass is half filled. Some will say, ma'am, glass is half empty. Both of you are correct. Ideally, both of you are correct. Glass is half filled. Glass is half empty. It's the way we look at that. Okay, both the things are correct. So this is HDI. HDI is development, how much we have. And this is HPI. HPI is deprivation, how much we don't have. So the thing is the same. The thing is the same. So it is the comparison of the deprivation of the dimensions. The same dimensions we will take, the longevity, the knowledge, and the standard of living. But instead of seeing the development, we will see the deprivation. Let me explain. This is a country. This is a country. Country A, country B. Same example, India, US. The two countries are there. Okay. Instead of looking at what India have and what US have, how much they have, to compare their quality of life, we have to see how much they have and how much they have, and we will compare them. That is HDI. In HDI, we will see how much they have. And here we will see how much they have. We compare the HDI of the two. Instead of that, we can see what they don't have and what they don't have. We can see their deprivation. Instead of seeing the achievement, we can see the deprivation. Here we were looking the achievement. How much knowledge they have, how much longevity they have, how much standard of living they have. Instead of that, we can see what they don't have. What they don't have. That is HPI. HPI is human poverty index. It's a measurement of deprivation instead of measuring the achievement. Here we were measuring the achievement and comparing them. Here we are measuring the deprivation and comparing them. So again, we can compare the quality of life. Here what these people don't have, what these people don't have, and then we can compare, and then we can decide which people have better quality of life. People say, got my point? It's an indicator of deprivation. Okay, it's an indication of deprivation. Human poverty index is what the country don't have. It's an indicator of deprivation. It's complementary to HDI. So what the country have, if you subtract it from the total, what the country don't have, you will get the answer. So it's like the glass is half empty. If you say the glass is half filled, it's human developmental index. It's achievement. And what the glass is empty, half empty. It's deprivation. It's HPI. How many of you got it? Give me a thumbs up. Got my point? So here I'm telling you HPI, Human Poverty Index. First of all, we have learned it's an indicator. It's a measurement of deprivation, not achievement. And it's complementary to HDI because HDI was a measurement of achievement and this is measurement of deprivation. First of all, we have learned that. Now the second thing, it is of two types. HPI 1, HPI 2. You will say, what do you mean by that? HPI 1 is for developing country, for like India. And HPI 2 is for developed country like US. So the criteria will be different. Okay, so dimensions are same. So let's talk about them, HPI 1 and 2 one by one. So HPI 1. First talk about HPI 1, that is developing country. Again, the three dimensions, longevity, knowledge, standard of living. Both the three same ही रहने हैं. Longevity, knowledge, standard of living. For longevity, here we see what is the probability that the person will not survive by the age of 40. By the age of 40. Person will not survive. What is the probability of that? Suppose again two countries, A and B, India and US, or say two developing countries. Any two developing countries, India and Pakistan, or India and any developing country. Okay. So people living here, today a newborn is born here. Okay, and today a newborn is born here also. So what is the probability that this newborn will not survive by the age of 40 if the newborn is surviving in this country only? And what is the probability that this newborn will not survive by the age of 40 if the newborn is surviving in this country? Tell me the percentage. So here the percentage is very less. This is a good country. Here the percentage is hardly 5%. There is 5% probability that the person will not survive by the age of 40, because most of them survive by the age of 40, because here healthcare facilities are good. Everything is good here. But here, this is a very poor country, or standard of living is not very good, quality of life is not good, and here chances are more, like 20% chance the person will not survive. So we are looking the chances, the probability the newborn will not survive by the age of 40. We are looking at the chances of the death. You know, in PQLI and in HDI, we were looking life expectancy at birth, life expectancy at the age of 1. We were looking the chances of survival. Here we are looking the chances of death. It is deprivation. Glass is half empty. We are not looking glasses half filled. We are seeing the glasses half empty. You are getting my point. I think, I assume that I'm trying my best. Yes. So here, so you can see it's the probability of not surviving by the age of 40. By the age of 40, what is the chances the person will not survive? The newborn will not survive by the age of 40. That indicates longevity. For knowledge, we look not literacy, correct it. It is illiteracy rate. See how many people are illiterate in the country. Don't see how many are literate, how many are literate. There are two countries now. See how many are illiterate here, how many are illiterate here. See the glass is half empty. Don't see the filled one, see the empty one. So see the illiteracy rate of the two countries and compare them. You are looking at deprivation. And for standard of living, you see how much percentage of population living in a country is not getting an improved water source. Currently, we drink water. This is my water. I got it from a purifier. Most of us drink water. We get it from purifier. If we are not getting it from purifier, we disinfected by using the chlorination and other methods. But there are certain people living in a country in very periphery who even don't get improved water source. So that will judge the standard of living in that country. So how many people didn't get the improved water source, and how many children are underweight, that will indicate the standard of living. That is HPI 1. For HPI 2, it is for developed country. This is for developing country. This is for developed country like US or other developed countries. Okay. Now here for longevity, we will see what is the chances the person will not survive by the age of 60. Instead of 40, we raise the bar to 60, because in US, nobody dies at the age of 40. There is no chance that someone will die at the age of 40, because it's a highly developed country. कोई मरेगा ही नहीं 40 की उम्र में. तो we have increased the age bar. So what is the chances today? So this is a country, this is a country. Both of them are developed country, well developed. One is US, one is UK, well developed countries. Okay, so today a newborn is born here, today a newborn is born here. Both are developed countries. Okay, so what is the chance that this newborn will not survive by the age of 60? What is the chance this newborn will not survive by the age of 60? Compare that percentage, that chance. That is the longevity. Number one. Okay, number 2, for knowledge, again we see the illiteracy rate, lacking literacy. Don't see literacy, see the illiteracy rate. Number 2. And number 3, for standard of living, we see how many people are under BPL, below poverty line. BPL, below poverty line. And here we have a fourth criteria also, that is social exclusion. Social exclusion means percentage of people who are unemployed in that country. What is the definition of unemployment? What is the definition of unemployment? Anyone who is seeking for a job, okay, and not getting the job for more than 12 months. That person is known as unemployed. So 12 months is the criteria. Till 12 months, the person is trying to get a job but not getting a job. So more than 12 months. So that is unemployment. So that is HPI 2. So we have seen HPI 1, we have seen HPI 2. I will revise all together. Don't worry. The last one, dekh lo ek, MDPI, then we will revise all 5 together. This one is last. So is the speed is good. It's a rapid revision. Huh? That's why speed is little bit more. Yes. So the MDPI, multi-dimensional poverty index. Nowadays, HPI 1, which is for developing country, and HPI 2, which is for developed country, both of them is replaced by MDPI. Nowadays, it is replaced by MDPI 2018 onwards. So we will look at MDPI. Okay, multi-dimensional poverty index, MDPI. It has replaced HPI. So again, it is having the same 3 indicators: the longevity like health, education like knowledge, and standard of living. So for health or longevity, there are 2 things: nutrition and child mortality. For education also, there are 2 things: school of years of schooling and attendance in the school. And for standard of living, there are six criteria. Cooking fuel, whether the person is using LPG gas or the person is using coal or charcoal for cooking. Sanitation, drinking water, whether the village or the people living in a village having that village electricity or no electricity, kacha house or pakka house, okay, and what assets the person is having. So don't learn it. Total 10 are there. Total 10 criteria are there. Okay, so that is MDPI. MDPI also range from 0 to 1. 0 to 1 for India, it's 0.12. According to which 27.5% population of India is poor. According to this, according to MDPI, 27.5% of population of India is poor. We are done. Can you help me in writing this? Can you help me in writing? We are done. Out of them, the most important are first two. Maximum chances you will get question here and here. But I told you these also because nowadays you don't know the level of the question and sometimes the question can be from these. But most commonly you get question from PQLI or HDI. Can we fill it together? These are the socio-economic indicators or indicators for quality of life. Please, people. Can we fill it quickly? We have to complete entire community medicine today. Chalo, come on, write down. So these are the indicators for quality of life. We are having 5 indicators with us. The first one is PQLI, Physical Quality of Life Index. The second is HDI, Human Developmental Index. Opposite or complementary of HDI is HPI, Human Poverty Index. This is an indicator of achievement and this is an indication of deprivation, which is of two type 1, type 2. Type 1 is for developing country and type 2 is for developed country. And last one is MDPI. What is MDPI? Multi-dimensional Poverty Index. MDPI. Got it? Chalo. We will start writing in each of them. You have to tell me. The dimensions are 3 only. That is longevity, knowledge and standard of living. These are the 3 dimensions. You have to tell me the criteria inside that. So for longevity, first talk about PQLI. What is not PQLI? First you talk about the longevity. Tell me how we compare the longevity in all of them. In PQLI, for longevity, we take life expectancy at the age of 1. We don't take life expectancy at birth, if you remember. In HDI, we take life expectancy at birth. Here we are taking at the age of 1. Here we are taking birth. Here we are saying the probability of dying. The probability the person will die by the age of 40 years. Here we will say the probability the person will die by the age of 60 years. Here we are seeing the chances of survival and here we are seeing the chances of dying. You get my point? And in MDPI, there will be 2 indicators. Don't learn them, but 2 indicators are there. Now coming on the next one. The next is the knowledge. Compare knowledge in all of them. Here for knowledge, we use literacy rate. Who is a literate? A person who can read, who can write, and who can read, write, and understand at least 1 language, more than 7 years of age. That is a literacy rate. That person is literate. Here we don't use literacy rate. We use mean year of schooling plus expected year of schooling upon 2. That is reflecting the knowledge. Here for knowledge, we use illiteracy rate. Not literacy, illiteracy. It is the glass half empty, I told you. Illiteracy rate in both of them. And here we use again years of schooling and attendance also. We use 2 criteria. Coming on the last one is the standard of living. For standard of living, in PQLI, we use infant mortality rate. And here in HDI, we use income, that is GDP per capita, real GDP per capita. Here in HPI 1, we use how many percentage of the people are not getting good water source, improved water source. And here we are saying the percentage of the people who are living below BPL. That's it. And here we have 4th criteria also, social exclusion, in which the percentage of the people who are unemployed, that is social exclusion. So we are done. Tell me the range of all of them. We are done. So here the range is 0 to 100. Here the range is 0 to 1. And here we don't have any range. And here again the range is 0 to 1 is there. Okay, tell me the values of India. Here the value of India, the current value of India is 65. Here the current value of India is 0.640, you can say. And here the current value of India is 0.121. According to which 27.5% population is poor. That's all about it. Give me a thumbs up. Please learn it. Please learn it. If you can't learn all 5 and you are getting confused, ma'am, it's a mess. Don't worry. Learn first 2. You are going to get question in the first 2. Most probably 99% you are going to get question on PQL and HDI. But for extra verge, if you are preparing for competitive exam and you don't want to skip any question, I told you all these. We are done. Can I start the next topic? We are done with health. So how is everything? The speed, the content. Shall we modulate it or we will continue with the same? You are comfortable. Can we go ahead? Can we go ahead? We are done with the first chapter, first topic, health. Now my second chapter, second topic I'm starting is disease. After health, let's start disease. So WHO has defined health. Okay, the health definition. Health ka definition is given by the WHO. What is the definition of health given by the WHO? Having three components. Health is a state of physical, mental, and social well-being. PSM. Health is a state of PSM, you can say. Physical well-being, mental well-being, and social well-being, not merely absence of disease. This is the definition given by WHO of health in 1948. Okay, but for disease, WHO has not defined. WHO has not given the definition of disease. No. So who has given the definition of disease? Some scientists, some epidemiologists. The name is Souser. Souser has defined the disease. It is not a WHO definition I'm telling you. I'm telling you the definition of the Souser. Souser definition of disease. So what is a disease? What is a disease? Do you know what is a disease? Listen now, listen. So you have to tell me three things. Disease, illness, and sickness. What's the difference between them? They are looking like synonyms. Disease, illness, sickness. You may be thinking, ma'am, these are the synonyms. No, these are not synonyms. These are three different things. Let me explain you. Let me explain you. I will give you example and explain you all three. Just a second. Let me open the chat. So disease, if in human body any physiological or psychological dysfunction occurs, so the person is diseased. For example, in my body some physiological dysfunction occur. Any of the system, my GIT, my cardiovascular system, my urinary system, so any of the system, my central nervous system, any of the system have some dysfunction, physiological or psychological dysfunction. So I will be having disease, but it is not necessary I have the symptom. Maybe I'm having some dysfunction inside me, but I'm not aware of that because it is very minute and I don't have any symptom of that. So I am diseased. I'm diseased, but I'm diseased because I'm having the dysfunction inside me. The moment I come to aware that I'm not well, I will be ill. So disease leads to illness. First, there will be disease inside me. There will be some dysfunction inside me. Some of the system, there is physiological or psychological dysfunction. And initially, I will not be aware because it is very minute. But the point, it will be significant that I will be aware that no, I'm not well today. I'm having some not good feeling today. I'm having some disease inside me. I'm having some problem inside me. So the awareness is the illness. The moment I came to aware, I am ill. I am ill. At that moment, I am ill. You're getting my point. And third is sickness. And since I am ill, I will write a leave because wherever I'm working in a hospital, in an institute, in a class, I will apply for the leave. What I will say? I am sick, so I will not be able to do my social responsibility. So I am taking a state of social dysfunction. The social dysfunction is the sickness. So disease leads to illness and illness leads to sickness. So in your school time, what do you write to your school teacher or principal? You write a disease leave, illness leave, or sick leave. We always used to write sick leave. Sick leave, that I am sick, so that's why I will be on leave from this to this. So sick leave means I am ill, that's why I am unable to perform my responsibility for the next few days and I will be on leave. So that is social dysfunction. So please learn the three definitions. If I'm having some dysfunction inside me, maybe physiological, maybe psychological, I am diseased. The moment I'm aware of that I'm not well, I am ill, and after that I will apply for leave. I will be socially dysfunction, and that time I am sick. If I am ill and I keep on working, I'm not taking the leave. So I'm not sick. I am ill, but still I'm working. So I'm not sick. I'm ill, but I'm not sick. But if I'm taking the leave from my workplace, so I will be sick. I hope you are getting the minute differences between them. People keep interacting now. Say, you got it? Now, there is a theory for the disease. How does the disease occur? So there is a theory. The name of the theory is epidemiological triad. In this theory, three components are there. For any disease to occur in human being, three things are required. Number one, there should be a host. Host means man, human or animal. So let's talk about the man. Man is a host. So सबसे पहले मैं खुद होनी चाहिए, मुझ में disease है. तो first there should be a man. Number one. Number two, there should be an etiological agent which can enter inside me and cause the disease. It can be bacteria, it can be virus, it can be fungus, it can be parasite. There should be some etiological agent that enters inside me and that will cause disease. And there should be an environment in which both of us are present. So there is an environment in which man is also present and the agent is also present. So we are interacting with each other in an environment so that the agent enters in me and causing the disease. So for causing disease, three things are required. What are the three things required? Am I live? Because the chat is just, you are not writing anything. Am I live? You are understanding the concepts, you are understanding the things. People say something. I guess I'm live. Okay. Okay, I'm sorry. So there are three components in the epidemiological triad. Number one, there should be a host, that is the human being. Number two, there should be an agent. The agent can be bacteria, virus, fungus, or parasite. And number three, they should be present in a common environment in which they can interact with each other. Okay, in which they can interact with each other so that the disease can occur in human beings. Then only the disease can occur in human beings. Okay, so you learn the three components. Now, if you learn the three components, now coming to the next thing, the iceberg phenomenon. You get many questions from the iceberg phenomenon. What do you mean by iceberg phenomenon? You take a jar, okay, fill water in that. Let's do an experiment. Okay, take a jar, fill water in that, and place 1 cube of ice in that. Have you tried it? Try to place 1 cube of ice in that. If you try to place 1 cube of ice in that, the maximum portion of ice will be submerged and only tip will be visible to you. A small tip will be visible to you. You can see a small tip. Small tip is visible to you and maximum portion is submerged. You can see only small tip is visible to you and maximum portion is submerged. You say, ma'am, okay, I got the experiment. If I put a ice cube in a jar of water, only tip is visible and most of the portion of the ice cube will be submerged. I got that. But how it is related to this subject? So we can compare the diseases in the community, with this phenomenon. So whatever we can see, people are coming to us. Now we are doctors. Of course, we all are doctors. The people who are attending my session, including me, we all are doctors. So we practice. Patient come to us. Okay, patient come to us and we cure the patient. We treat the patient. We do the diagnosis in the patient. Whatever we can see, the patients are coming to us as only a small tip. Maximum persons who are diseased are hidden in the community. We can't see them. So the persons who are diagnosed, who are already diagnosed, who have the symptoms, who are symptomatic, who have the clinical features is the tip. It's only small percentage. But maximum persons who are ill, who are diseased, they are asymptomatic. Either they are carrier or they are undiagnosed or there is latent state. They are in latent state. They can be in hidden state. They can be in dormant state because they are asymptomatic. So maximum burden, because they are carriers. So maximum burden is that. So that is the submerged portion. You got my point? So submerged portion is maximum. It is the biggest chunk you can see. Biggest chunk is the submerged portion. It's asymptomatic, carrier, dormant cases, hidden cases, latent cases, undiagnosed cases, subclinical cases. And here the diagnosed symptomatic clinical feature, it's only small tip. So whatever money we are earning is from the tip only. So clinician is always interested in the tip and the epidemiologist is interested in the submerged portion. So clinician is interested in the tip. Clinician, okay, we all are clinicians. Okay, epidemiologist is interested in the submerged portion. So here the tip is coming to the doctor. We are not going home to home. Is there anyone who is ill? Is there anyone who is ill at your home? No, patients are coming to our clinic, to our hospital. But here we are going to the patient because they think they are well. No, actually they are not well, but they think they are well because they don't have the symptom. So we have to go to them and apply the test on them. Here we apply the diagnostic test. Here we apply the diagnostic test on them. Here we apply the screening test on them. So for the tip, we apply diagnostic test and clinicians are interested in the tip. And for the hidden portion, for the submerged portion, epidemiologist is interested and we apply screening test. So please compare and contrast. This is iceberg phenomenon. Can you see the iceberg phenomenon? Everyone on the screen? Everyone on the screen. Can you see the iceberg phenomenon? Here you can see the tip is very small. Appreciate the tip. A small tip is there and appreciate a big submerged portion. Can you see a big hidden submerged portion is there? A big submerged chunk is there. So the tip is indicating the clinical cases and the submerged portion is indicating the asymptomatic hidden cases, maybe carrier, dormant cases, latent cases and subclinical cases. They are asymptomatic. Okay, clinician is interested in tip. Epidemiologist is interested in the hidden portion. Diagnostic test is applied on the tip and screening test is applied on the hidden portion. So you get questions on the iceberg. Say yes if you got it. Say yes. So this is iceberg phenomenon. The diseases in the community are compared with the iceberg. They have a tip, they have a hidden portion. The tip is indicating the clinical cases and the hidden portion is indicating the apparently healthy, subclinical, undiagnosed, asymptomatic, carrier, latent cases, the hidden cases. Okay, got it? So that is the thing. So, iceberg phenomenon is shown by all the diseases except four. There are 4 diseases which does not show iceberg phenomenon. There are 4 diseases which it does not, there are 3 diseases which does not show iceberg phenomenon. Why they don't show iceberg phenomenon? They have only tip. These 3 diseases have only tip. They don't have submerged portion. They don't have carrier. So it's all or none phenomenon. होगी तो पूरी होगी, नहीं तो नहीं होगी. इनमें hidden कुछ नहीं है. Once the person have rabies or the person have tetanus or the persons have measles, they are the cases. There is no carrier, there is no asymptomatic, there is no latency, there is no dormancy. So they don't have submerged portion. They have only tip. They don't have submerged portion. So iceberg phenomenon is not applicable on the three diseases. Name the three diseases. You get question on that. Name the three diseases. The three diseases is rabies, tetanus and measles. You can learn a mnemonic Raipur to Mumbai. Rabies, tetanus, measles. Rabies, tetanus, measles. So Raipur to Mumbai. Raipur to Mumbai. Rabies, tetanus, measles. These three diseases have only symptomatic cases. They don't have asymptomatic cases, dormant cases, carrier. No, they have only tip. They don't have submerged portion. So iceberg phenomenon is not applicable on them. Apart from them, all the infectious diseases, iceberg phenomenon holds good. But on these three diseases, iceberg phenomenon is not applicable. Can I come on the next topic? People keep interacting. Can I come on the next topic? The next topic. Okay. So, sequence of disease control. So, there are three things which will occur one by one. If you want to control a disease, you have to do it in a sequence. First of all, disease should be controlled. Then disease is eliminated and then disease is eradicated. You see, ma'am, what is the difference between control, elimination and eradication? See the three things. First, you learn the sequence. You cannot directly eradicate a disease from the community. No, you cannot do so. First, you have to control the disease. Then you have to eliminate the disease. And finally, you can eradicate it. So you understand the definition and you get many questions on this concept. Got it? So control, elimination and eradication, we will see one by one. Everyone knows the epidemiological triad. Just now I taught you because it is related to that. If you don't understand the epidemiological triad, you can't understand these terminologies. So what is epidemiological triad? How does a disease occur? For occurring of a disease, three things are required. Number one, man. Host is man. Number two, agent. It can be bacteria, virus, fungus or parasite. There should be an agent, okay, which enters the man. And there should be an environment in which both are present. The man is also there and agent is also there. They are present in a common environment so that the agent can enter in the man and the man can have the disease. So three things are required. Host, agent, and they are present in a common environment for interacting with each other. You got this. Now, if you got this, I will help you in understanding these three terms one by one. Let's start with control. One by one. So let's start with control. Please, everyone here. Okay, please, everyone here. Let's start with the control. In the control, please see, agent is present in the environment and host is also present in the environment. Both are present in the environment. Agent is there, host is there, but agent is present in a lower level. It is present in a very low level so that it is not a public health problem. So that is the disease under control. So here the agent is permitted to persist in the environment. Agent is present in the environment. Okay, but at a level, it ceases to be a public health problem. It is not a public health problem. So it is present in the environment, but in a very low concentration. So it is entering the human, causing the disease in the human, causing the disease in the man, but not a public health problem. So I will say the disease under control. We are trying to control tuberculosis like that. Okay. So Mycobacterium tuberculosis is still present in our environment. It is not zero. It is still present, but it is present in low burden. The burden is low so that less humans are affected. It is not a major public health problem. So I will say the disease under control. That is the control ka definition. So control, after control, the second thing is elimination. So we have seen the control. Now after control, I am coming on elimination. Let me come on elimination. What happens in elimination? See here. See here. The agent is present in the environment. Please see. Please see. Host is also present in the environment. Both are present in the environment. Okay. But agent cannot enter the host. The transmission is interrupted. Mind my words. I'm saying that transmission is interrupted. Agent is present in the environment. Host is also present in the environment. But the transmission of the agent to the host is interrupted. How the host will have the disease? When the agent enters inside the host. Then only the host can have the disease. The host is human. If the bacteria enter in me, then only I will have the disease. Virus enter in me, parasite enter in me, fungus enter. Then I will have the disease. Otherwise, how I can have the disease? So there is a bacteria present in the environment. Virus, parasite, fungus, they are present. But they cannot enter in me. So I will not have the disease. So I will say the disease is eliminated. So this is the definition. Here the transmission is interrupted. The transmission of agent to host, this transmission is interrupted. This is the definition. So interruption of transmission of a disease in a geographical area, but the causative agent is still present in the environment. Agent is still present, but it cannot enter the human. So disease is eliminated. We use this terminology, the disease elimination. We use this terminology for a geographical area. Okay, maybe for a country. In India, many diseases are eliminated. In India, till now, 4 diseases are eliminated. Okay, For example, dracunculosis is eliminated in 2000. In 2000, leprosy is eliminated in 2005. Yaws is eliminated in 2006, and tetanus, maternal tetanus and neonatal tetanus, they are eliminated in 2016, most recently. Okay, these 4 diseases are already eliminated from India. Eliminated. I mean, their agents are present in the environment. Okay, the guinea worm is present in India. है ना, leprosy में mycobacterium tuberculosis, mycobacterium leprosy is present. Okay, the agents are present, but they cannot enter the human. Okay, the transmission is interrupted. The next disease which we are targeting to eliminate in India is polio, kala azar, and lymphatic filariasis. These are the target we have not yet eliminated. We are trying to do so, but these are already eliminated. These are already eliminated. These are next to target. Okay, this is elimination, and it is used for a geographical area like a country. The third and the last is eradication. Can I start eradication? See, everyone on the screen here, agent is removed from the environment. In the environment there is no agent, it's extermination. Only host is present in the environment. Agent is absent. Agent is absent. There is extermination of the agent. Agent है ही नहीं, गायब, खत्म. It is tearing out by roots. हिंदी में कहूं तो जड़ से उखाड़ दिया. अगर if you understand हिंदी, जड़ से उखाड़ फेंकना. So we are tearing the agent by its roots. It's absent in the environment. न रहेगा बांस, न बचेगी बांसुरी. एजेंट ही नहीं है तो काय की डिजीज? देयर इज नो बैक्टीरिया, नो वायरस, नो पैरासाइट, नो फंगस. सो हाउ कैन आई हैव द डिजीज? दे आर एब्सेंट इन द एनवायरनमेंट. आई एम हैविंग एन एनवायरनमेंट व्हिच इज फ्री ऑफ ऑर्गेनिज्म. ओ माय गॉड, है ना? सो द डिजीज इज एराडिकेटेड. गॉट माय पॉइंट? इट इज ऑल और नन phenomenon. It's the complete absence of organism. Okay, organism is absent, the agent is absent. It's a global term. We use this term only when the agent is absent on entire earth. Earth is our planet. Okay, Earth is our globe, our planet on which human life exists. Till now, the discovery is that. So human life exists on the globe, on the earth, on the planet Earth. So when the agent is absent on entire earth, it is not only in India. The agent is absent in India but present in other countries. I cannot say it is eradicated. It can again come into the Indian environment. No, if it is absent in entire earth or entire globe, then only I can use this term. So this is a global term. In contrast to elimination, which was a geographical term. Elimination can be used for the country. There can be a disease which is eliminated from India but not from other countries. It's okay. Anna, they will eliminate later on. But in India, it is eliminated. Okay. But eradication is a term used only when the entire earth is free of that agent, the environment of entire earth. So till date, only one disease is eradicated from the world. Only one disease is eradicated from the world. Name of that disease is smallpox. What is that historical date? It is 8th May 1980. 1980, before you born. By the way, before I born. I'm also born after 1980. By the way, I'm not that old. Okay. So before we all born, we can say, before we all born, that was eradicated in 1980. But ask your parents and ask your grandparents at their era, that was a disease, that was a horrible disease at that time. They call it chota chechak. It was a very terrifiable disease, that is smallpox. It is eradicated on 8th May 1980. After that, not even a single case we found. So the agent for that is a virus. The name of the virus is variola virus. It's the agent of the poxviridae family, and it is still present in the laboratory, but it is not present in the environment. The next diseases which we are targeting to eradicate globally is the polio, measles, and guinea worm. We are targeting. We have not yet eradicated, but we are targeting to do so. You got my point? I will cover everything, Sarah. Yes, I will cover all these topics. They are already there in the line. Okay, don't worry. Okay, chalo. Can we go ahead? Yes, I will provide the PDF also. Okay, chalo, let's go ahead. So we have done the 3 things. What 3 things we have done? Can you define the 3 things? So let me draw the epidemiological triad for you. In epidemiological triad, the disease will only occur when 3 things are there. Number 1, there should be a host. Host is human, the man. It can be animal also, but for ease of understanding, let's say man. Okay, there should be an agent. The agent can be anything. It can be bacteria, virus, fungus, parasite. Okay, and they should be present in a common environment. If the 3 things are coming together, the disease can occur. So let me write the disease here. The disease can occur. So this is epidemiological triad theory. Now, what is control? What is disease control? What is elimination? And what is eradication? Can you define the 3? In control, the agent is present and the host is also present. Both are present in a common environment. Both are present. But agent is present in a low burden. So that the agent can enter the host. It can cause disease in the host, but in a low burden, so that it is no more a public health problem. That is, the disease is controlled. In elimination, the agent is present in the environment. The host is present in the environment. Again, the agent is present in the environment, the host is present, but agent cannot enter the host. The transmission of agent to host, this transmission, look at the arrow, the transmission is interrupted. So when we interrupt this transmission, the disease is eliminated. The disease is eliminated. Okay, and it's a geographical term. And whenever the agent is absent, agent is not present in the environment, only host is present in the environment, agent is absent, extermination of agent, tearing off by its root, it is known as eradication. It's a global term. Let's talk about India. In India, till now 4 diseases are eliminated and 1 is eradicated. You should know these 4 names and this 1 name. The 1 disease which is eradicated globally throughout the globe, it's smallpox on 8th May 1980. It is caused by variola virus. And the 4 diseases which are eliminated from India, you know their names. Okay, so you should know, and their years also. Can we go ahead? So that's the thing. Okay, so we are done with this topic. Now the next topic is level of prevention. I guess this is the last topic of this chapter. Then I will move on the next chapter. I will cover all these topics. Don't worry. Okay, so level of prevention. If you people are interested, I will keep on teaching. Don't worry. I will cover all the topics, but keep interaction. So the session should be interactive. Okay, chalo. So coming on level of prevention, the next topic. We are done with the sequence of control, elimination, and eradication. We are done with that. The next thing is level of prevention. What is level of prevention? Can you tell me what is level of prevention? Let's talk about level of prevention. So what is level of prevention? There are 4 levels of prevention. I'm teaching you a subject. What is the session of? This session is of which subject? I'm teaching you community medicine. Either say community medicine, some people say social medicine. Okay, some will say preventive medicine, preventive and social, PSM, preventive. It's a preventive medicine I'm teaching you. So I'm not interested in treatment. I'm interested in prevention of the disease. Have you heard a proof of prevention is better than cure? So we have to prevent the diseases. Anna, it's better than cure. Okay, so prevention, we want to prevent the disease. Anna, in this subject, we want to prevent the disease. So there are 4 levels of prevention. We can prevent the disease. What are the 4 levels of prevention? Primordial, primary, secondary, tertiary. We will take an example to understand them. You get many questions on this. Please see here. Suppose there is a normal life going on. My life, your life, normal life is going on. We don't have any disease yet. For example, my life, I don't have any disease right at this moment. I'm not sure about the future, but at this moment, I'm healthy. I think so. Okay, chalo. So there is a normal life. Okay, so the risk after the normal life, the risk factor can enter. Okay, now let's take an example of a kid, a 3-year kid. Imagine a 2-year or a 3-year kid is there. A 3-year kid is there, and the father of the kid or the mother of the kid or any caretaker of the kid is counseling the kid ki beta, listen, child, dear, don't smoke. So kid said, Mama, Papa, I don't smoke. Why you are saying that don't smoke? I don't smoke. I'm a kid. How can I smoke? So they say, yes, we know that you don't smoke, but in future also you don't smoke. We are discouraging the habit of smoking in future also. So risk factor have not yet appeared. The child have not yet started smoking. You know, smoking leads to lung cancer. We all know smoking is a risk factor for lung cancer. If someone smokes, there is high chances of having lung cancer in future. There can be a chance. Okay, so smoking is a risk factor for lung cancer. But child don't smoke, so risk factor is absent. So even before the risk factor appears, we are eliminating it कि वो future में भी ना आए. So child don't smoke, but we are making sure that in future also this child don't smoke. So a 3-year-old child, we are counseling the child. We are discouraging the habit of smoking or bad lifestyle. Not only smoking, the alcohol and all. So we are encouraging the child that you don't smoke, you don't drink, but in future also you don't do so because it leads to many diseases. So before the risk factor appears, we are eliminating the possibility of its appearance. The best level of prevention, it is known as primordial prevention. In primordial prevention, we are taking the action before the even risk factor appears. रिस्क फैक्टर के आने से पहले ही हमने उसका आने का बंदोबस्त बंद कर दिया. Got my point? So before the risk factor appears, we are eliminating the possibility of its appearance. So that is the primordial prevention, the best prevention, number 1. So such a child will never smoke in future, never will have lung cancer. So we are eliminating the possibility long before the risk factor appears. Now imagine a teenage. Going to a college, maybe a 20-year-old boy, and he smoke. You know, smoking is very looking cool nowadays. Many kids smoke. Okay, so he is smoking, but he don't have lung cancer yet. The kid, the teenage, the boy don't have lung cancer, but he had already started smoking. So we can counsel that teenage that please listen, boy, don't smoke. If you keep on smoking, you can have many diseases. You can have emphysema, you can have lung cancer and many other diseases. Smoking is injurious for the health. Don't do so. So we are doing primary level of prevention. So risk factor already present, but the disease is absent, and we are intervening in between. So risk factor is present, but disease is absent. In primordial, even the risk factor was absent. Here, at least risk factor is present, but disease is absent. So here we are taking the action. It is known as primary level of prevention. Okay, if the boy is following it and quitting the smoking, it's very good. But imagine the boy is not listening. Boy is saying, okay, but I will keep on smoking. You do your own job. I will keep on smoking. And what will happen in future? Now, the boy already become 40-year male, and this 40-year male already have lung cancer, early stage. So here the risk factor is already present and the disease is already there. Here he's already having the lung cancer, but in early stage. Lung cancer is already there. Smoking is already there. Lung cancer is already there. So disease is present. Now what we can do? We can ask this person, this man, that take treatment earliest. Do the diagnosis, take radiotherapy, chemotherapy, surgery, whatever is the treatment, take it earliest. So we are intervening where? Early stage of disease and advanced stage of disease, so that the disease cannot be advanced, it cannot metastasize. So that before the disease metastasize or before the complication appears, before the late stage, we are intervening. So we are intervening between early stage and late stage. That is secondary level of prevention. Secondary. So we are halting the disease in the initial stages only by secondary prevention. And finally, if the person already have the mats, we can do nothing. We can only do the tertiary rehabilitation, that is rehabilitation. Tertiary prevention is simply rehabilitation. If the person already have the disease, and that to advanced stage, so we can just do rehabilitation, the social rehabilitation, the vocational rehabilitation, the physical rehabilitation, various types of rehabilitation till the person either recover or death. That's it. So there are 4 levels of prevention. What are the 4 levels of prevention? Primordial, primary, secondary, tertiary. These are the 4 levels of prevention. In primordial, the action is taken before risk factor appears. Before even risk factor appears. The best example, counseling a 3-year-old kid that in future also you don't smoke. In primary, we are taking the action after risk factors. After risk factor already there, but before disease, we are taking action here. After risk factor, but before disease. In secondary, we already have the disease. So risk factor is there and it already lead to disease, but disease is an early stage. So we are taking the action between early and late stage of the disease. So we are taking the action here. Got my point? So the disease do not advance into late stage, and here the disease is already in late stage. So we are just doing the rehabilitation. I hope you got it. Got my point? So these are the 4 levels of prevention. I hope you all got it. So these are the levels of prevention. Each of them have two modes of intervention. Please understand, what do you mean by modes of intervention? You got the 4 levels of prevention, yes or no? You got the where we are taking the action, at which level we are preventing the disease. See the level, at which level we try to halt it. That is a level of prevention. So 4 levels of prevention. Each of them have 2 intervention. How to do that? 2. So total 8 interventions are there. Let me explain you the interventions also. So 4 levels of prevention have 8 levels of prevention. Each of them have 2 interventions. Let me tell you the intervention. Let me talk about the primordial. So take the same example. I want to take action before the risk factor appears. Before risk factor is absent, even before that, I want to take the action. So I can do by 2 means. I can do individual education, like the same example, kid. There is a kid. See the example. This is a kid. This is a 3-year-old kid. And the father is counseling the kid that, beta, dear, darling child, don't smoke in future also. Okay. So the child don't smoke. Of course, the risk factor is absent. So even before the risk factor appears, we are eliminating it. So that is 1-to-1 counseling. That is individual counseling we can do. Or else we can show it on the television, on the radio, in the newspaper. So it will be a mass education. The person who don't smoke, they looking at the advertise or the, before we watch a movie, there is an ad in the theaters that smoking causes cancer. So someone who don't smoke, looking at that, he will not smoke in future also. So that can be the mass education. So 2 modes of intervention, individual 1-to-1 and mass education. So 2 modes of intervention for the primordial. For primary, we are done with primordial. So what is primordial? Here the action is taken before the development of risk factors. This is the best level of prevention. Two modes of intervention, individual and mass. In individual, may 1-to-1 counseling and mass education. Okay, coming on the primary. In the primary, the action is taken after risk factor, but before disease. Risk factor is present, but disease is absent. So risk factors are present, but disease have not yet taken place, and we are taking the action in between. That is primary. So here two interventions are there. What are the 2 interventions? Health promotion and specific protection. One is health promotion, one is specific. Now please understand, health promotion is non-specific. It is non-specific. If I'm saying to you, please, you should have a healthy lifestyle. You should get early in the morning. You should have a physical activity. You should go to yoga, jogging. You should eat a balanced diet. You will say, ma'am, which disease it will prevent? Which disease? I will say many diseases that will prevent. It is non-specific. If I say you should have an environmental protection, sanitation around you, you should wash your hands before eating, and you should have a balanced diet. Okay, so it is preventing non-specifically many diseases. It is non-specific in nature. But if I am asking you to take a particular vaccine, Hana, take the vaccine for COVID. So COVID wala vaccine will prevent only from corona. If I ask you to take the vaccine for BCG, I'm giving BCG to a newborn. BCG will prevent only for the TB. Okay. OP will prevent only for the... So vaccine prevent for that particular agent. It is not non-specific. It is specific. If I'm giving you chemoprophylaxis, it is for specific. Fortification, for example, salt is fortified with iodine. That is for prevention of goiter. So only goiter is prevented, not other diseases. है ना? Iodine देने से मुझे iron deficiency anemia में कोई फायदा नहीं मिलेगा. Only I can preventing the goiter. Okay. Usage of bed net for the mosquito. Okay. So these are the specific protection. So either non-specific, that is health promotion, or specific protection. Please understand that. Please understand that. You are getting it. We are getting it. So like that. Now the secondary level of prevention. In the secondary level of prevention also, here the disease is in early stage, and we are halting the disease in early stage to prevent the complication or advanced stage. We try to arrest the disease in early stage. Okay, that is secondary level of prevention. There are two methods. Either do the diagnosis or do the treatment. Early diagnosis, early treatment. Patient already have the disease now. Now do the diagnosis, do the treatment. That's it. You cannot do anything else. The disease already is there. Disease already is there. Okay, and finally tertiary rehabilitation. Tertiary prevention, in which there is two things. One is disability limitation and one is rehabilitation. For example, the person is having polio. We can do two things. Number one, physiotherapy, so that it don't advance. It is disability limitation. We can do the physiotherapy, or we can provide the crutches for the walking. That is rehabilitation, so that the person already have the paralysis. It's okay, but now at least with the help of crutches he can walk. So we are providing the crutches. That is a type of rehabilitation. How many of you got it? How many of you got it? We are done with the levels of prevention. Are you ready for some questions for the levels of prevention? What I taught you? I taught you there are 4 levels of prevention. Primordial, primary, secondary, tertiary. You know their definitions? I guess you know. Now can you tell me two modes of intervention for each of them? So total 8 modes of intervention are there. Can you tell me the modes of intervention? For primordial, we are having 2 modes of intervention: individual education and mass education. Individual is one-to-one, like the father and the child. Okay, individual education and mass education. We just educate the person so that don't do in future. Okay, for primary, there are 2. Health promotion. Health promotion is non-specific. And specific protection is for specific agent. Specific protection, I have given you the example. For secondary, it's 2 things: diagnosis and treatment. The disease is already there. Now you can do the early diagnosis and treatment. And for tertiary, you can do 2 things: disability limitation. Limit the disability. Disability is already there. The person is already having tertiary. Already having the advanced disease. So disability limitation and rehabilitation. So these are the 8. Now what the strategy ahead? I will ask you 15 questions one by one. For each of them, first you have to tell me the mode of intervention. Is it primordial or primary or secondary or tertiary? After telling the mode of intervention, level of prevention, you have to tell me the mode of intervention also. If you are saying primordial, is it individual or mass? If you're saying primary, is it health promotion or specific protection? If you're saying secondary, is it diagnosis or treatment? If you're saying tertiary, is it disability limitation or rehabilitation? So you have to tell me two things. First, tell me level of prevention. Level of prevention. First, you tell me level of prevention and then tell me mode of intervention. Tell me two things for each of them. Are you ready? If you're ready, give me a thumbs up. If you're ready, give me a thumbs up. I'm waiting for your thumbs up. Then only I will proceed. Are you ready? Shall I put the first example? So the first example is in front of you. Read the question and tell me the answer. Okay. So there is a person who is having cough and fever. Fever. So person already have the disease. Come on. The person is coming you with the symptoms. Disease to पहले से ही है. The person already have the disease. Since 3 weeks. The person already have the disease. Now the person is coming to the DOTS clinic and we are collecting the sputum. We are collecting the sputum of the person. So what basically we are doing? We are collecting the sputum. So we are taking the action where? Is it primordial, primary, secondary or tertiary? First you write that. Is it primordial, primary, secondary or tertiary? Yes, I'm asking. Yes. So the disease is already there. We are preventing and halting the disease in early stage. So it is a secondary level of prevention. Absolutely right. And we are doing the diagnosis, not the treatment. So it's secondary level of prevention and we are doing the diagnosis. So that is the answer. That is the answer. Coming on the next question. The next question is in front of you. See the question. Again, there is a patient with the sputum positive. The patient is already having sputum positive, acid fast bacilli, sputum positive. Patient is already having the TB. We have categorized it cat1 under RNTCP, and we are giving the drugs for the treatment. So again, it's secondary level of prevention because the disease is already there. It's sputum positive, but this time we are giving the treatment. This was secondary, but we were doing the diagnosis. This is secondary, but here we are doing the treatment. Okay, the next question. The patient is coming with fever and chills. Again, the patient have the disease. The disease is already present. So we are talking about a secondary level of prevention. Coming to a malaria clinic, and we are collecting the peripheral smear. So secondary level of prevention, and we are doing the diagnosis. Like that. Okay. The next question. The person is sleeping inside a bed net. Suppose I'm sleeping inside a bed net. Why I'm sleeping inside the bed net? Because there may be many mosquitoes at my home. These are the mosquitoes. So I want that mosquito shouldn't bite me, because if the mosquito will bite me, I can have malaria, I can have dengue, I can have all the mosquito-borne diseases. Okay, mosquito-borne diseases are many. So I want to prevent myself. So I am preventing a bed net so that the mosquito do not bite me. So here the risk factor is present. Who is the risk factor? Risk factor is mosquito. These mosquitoes are present at my home, but they do not bite me. So I don't have disease yet. So disease is absent. I don't have malaria yet. Okay, so risk factor is present, but disease is absent. So it is primary level of prevention. It's not primordial, it's primary. It's primary level of prevention. In the primary level of prevention, there are two options. Is it non-specific or specific? I mean, it is health promotion or specific protection. So by applying bed net, I can have prevention only of the diseases which are caused by the mosquito bite. So it is specific protection. I cannot get protection for the anemia. I cannot have protection for the goiter by applying the bed net. By applying the bed net, I can have protection by mosquito-borne disease. So it's specific protection. So my answer is primary level of prevention and specific protection. So you have to be very specific for your answer. You are getting my point. The next is we are giving OPV vaccine to a child. Do boon zindagi ke. You may have heard this punchline. Okay. So we are giving the 2 drops of the OPV to a child. So what actually we are doing? So the polio virus. The polio is caused by a polio virus. The polio virus is present in our environment, here, there, in the water, in the food, in the water. It is present. It enters via injection. Okay. So it is present. It is present in the environment, but the boy don't have polio yet. So the risk factor is present. Risk factor is present everywhere. Okay. But the boy don't have the polio. So we are taking an action in between. So risk factor is present, but the disease is absent. Again, it's a primary level of prevention. It's a primary level of prevention. It's a primary. All vaccines are primary level of prevention, not only OPV. Please understand. All vaccines, learn by heart. All vaccines are primary level of prevention. And here, by giving OPV ka vaccine, we are preventing only for polio. We are not preventing for TB, for any other disease. It is specific protection. So primary level of prevention and specific protection. So say both things. You are getting my point. You can get a question on the level of prevention and mode of intervention. तुम्हें दोनों पता होना चाहिए. So level of prevention is primary and mode of intervention is specific protection. You are getting my point. That's it. So the next question. Okay, you can see we are using a urine strip for detecting the sugar in the urine to screen the diabetes in a community. We are going in a community. This is a colony. There are 100 people living in this colony. So we are testing the urine of all of them. We are collecting the urine and we are applying the strip test in urine of all of them. So what basically we are doing? So we are screening. So screening comes where? So the screening here, the strip test will be positive only in those which have the diabetes. Here, some of them, the urine contain the sugar. Some of them urine have. So strip test will be positive there. So the disease is already there. But in early stages, people do not know it. It's an early stage. Disease is already present. Please understand. Disease already hai. Tabhi to strip positive aayegi. Strip will come positive only if the person have diabetes. But the person don't know that I have diabetes. But the urine contain the sugar. So person have diabetes in early stage. So disease is there in early stage and we are taking the action there. So we are doing secondary level of prevention. All screening tests come in secondary level of prevention. It's secondary level of prevention, number 1. And we are doing the diagnosis, not the treatment. So secondary level of prevention with 2 options are there. Diagnosis and treatment. We are doing diagnosis here. So secondary level of prevention and diagnosis. So please learn 2 things by heart. All vaccines or immunization. Please learn. Vaccine, immunization, one and the same thing. It is primary level of prevention. Primary level of prevention. Please learn. You very frequently get question on that. And all screening test, whatever the screening test may be different time, different exam. Screening test, hai na? All screening tests are secondary level of prevention. Please learn it. Every exam, every time you get different examples, different vaccine they will give you, different screening test. But any vaccine, it's primary level. Any screening test, it's secondary level. You are getting my point? Okay, the next is, suppose we are going to a village community. We are going to a village community and we are educating them to prevent the spread of the malaria. In this village, malaria is very common. Malaria, and we want to prevent it. So we are educating the people that don't have stagnant water at your home, and you should use the, the gels, and this are available, the insecticides. You should use all that. So we are educating how to prevent malaria. So what we are doing? So here the risk factor is already present. The mosquitoes are present in the village. The mosquito is the risk factor. Okay, but they don't have malaria yet. The disease is absent, and we are taking an action. We are taking action here. So risk factor is present, but disease is absent. So it's a primary level. It's a primary level. It's a primary level, and it's health promotion. Health promotion or specific protection, whatever you say. Okay, got it. So let's skip it. The next question. There is a 5-year-old child. Okay, and the father is discouraging the child from harmful lifestyle. That is, don't smoke, don't drink in future, like that. So what is this? Is it primordial, primary, secondary, or tertiary? Very commonly asked question. So your child don't smoke. Of course, none of the child smoke. 5 year का बच्चा कभी smoke नहीं करेगा. So your risk factor is absent. Even risk factor is absent. Disease का तो सवाल ही नहीं है. Even risk factor. So we are taking the action even before the risk factor appears. So it's primordial level of prevention. This is primordial level of prevention, and it is 1-to-1. Individual. Okay, the last question. We are providing crutches. Can you see? We are providing crutches to walk. The crutches to walk to a child who already have the polio. So polio is already there. Paralysis is already there. It's advanced. It's paralytic. Already there. So it's tertiary level of prevention. The disease is already advanced. Polio is already there. And that too advanced. The person already have the paralysis. You cannot reverse it now. So this is tertiary level of prevention, and we are doing the rehabilitation. Tertiary level of prevention, and we are just doing the rehabilitation. I hope you got it. We can skip the further questions. I hope you all got it. Can I come on the next topic? You got it or you didn't got it? Say something. So can we go ahead? Are you people interested? So the next thing, I want to explain you a sequence. Frequently you get question on that. I want to explain you a sequence. Which exactly you are asking? Why was not previous slide primordial? Dipadyuti. Which exact example you are asking for primordial? Tell me. You write down the example for which you are asking exactly. Okay, can we go ahead? Disease, impairment, disability, and handicap. This is a sequence. Please, disease lead to impairment. Impairment leads to disability, and disability leads to handicap. Disease directly do not lead to handicap, and you cannot reverse the sequence and haphazard the sequence. You have to learn them in a sequence. Let me explain you why they occur in a sequence. First of all, there is a disease. Disease lead to impairment. Impairment lead to disability, and disability lead to handicap. You can understand this if you understand the meaning behind them. Let me explain you the definition, and better than a definition, I will give you an example. Okay, you will understand it better. So what is a disease? If in human body, any abnormal condition occurs, any abnormal condition that impairs the function, that can be physical, that can be psychological. Inside me, if any abnormal condition occurs, so I will have a disease. Okay, that will impair my function, maybe physiological, maybe psychological. So I will have the disease. Number one, this is known as disease. What is impairment? Impairment is loss of either anatomical structure in the body, or psychological function, or physiological function. Because of that abnormal condition, there is loss of something in the body. Either I am losing an anatomical body part, or I am using a psychological component, or I am using a physiological function. So loss is known as impairment, because of which I cannot do my day-to-day activity, which was I am doing normally before that. I can walk normally, but now I cannot walk. I cannot go to my work, because of which I am unable or restricted to do my activity, which was normal for me initially. So that is I am disabled. And because of which I will have a disadvantage in the society, and that is known as handicap. Let me give an example. For example, there is a person who got unfortunately an accident. So accident we can compare with a disease. It's an abnormal condition. Accident is an abnormal condition that we can compare with a disease. In the accident, unfortunately, the person loses his foot. So loss of an anatomical body part, anatomical, physiological, or psychological, any loss can be there. Here anatomical loss is there. So loss of foot is impairment. So disease is leading to impairment. Okay, now the person cannot walk. Initially person was walking very normally, but now person cannot walk. So walking is considered normal for this person, but person cannot walk. So person is disabled. So impairment is leading to disability. Disability is inability to perform an activity which is considered normal for that person. Inability to perform an activity which is considered normal for that person. So that is known as disability. loss of an anatomical, physiological or psychological function is known as impairment, and any abnormal function, any abnormal condition is known as disease. Now because of which he is fired, the person cannot walk now, so person is fired from his job. Initially he was doing a job, maybe he was a salesman, he was having a job in which he has to walk a lot, and that's why he is fired. Unfortunately he is having a social disadvantage. Because of his disability he got a social disadvantage, so I will say the person is handicapped. Imagine a person who cannot walk but working, है ना, he is having some work which is sitting job only, so I will say the person is disabled, the person is not handicapped because the person is still have a job. But imagine a person cannot walk and loses the job also because he cannot walk, that's why the person loses the job. So I will say the person is disabled, and because of the disablement he become handicapped. So please choose your words and options very wisely. You are getting my point? If I say person loses the food, that's it. My question is person. So you get three type of questions here. The first question, there is an accident, and in an accident the person lose foot. The person lost the foot. Okay, the person lost foot. So what is that known as? In an accident, person lost foot and person can't walk. What it is known as? And in an accident, the person lost foot, the person can't walk, and because of which the person loses the job. What it is known as? So three questions are different. Options will be same ABCD. Option यही चाह रहे हैं, disease, impairment, disability, handicap, ABCD. So what you will choose? In the first, I will choose person can't. A person just loses an anatomical part. So I will say the person is having. What is the first one? The person is having impairment. Impairment is loss of anatomical, physiological or psychological part. So impairment. The person can't walk. Person can't do an activity which is considered normal for that person. So I will say the person is disabled. This is disability. And because of which the person is having a social disadvantage. Person loses the job. So I will say the person is handicapped. So you know the question 3 times in FMG exam only. 3 times different question is asked. I mean the initial is same. The initial question is the same. But where they are ending that matters. They are ending the question just here. So you have to opt for impairment. They are ending the question, the person cannot walk, you have to opt for here. And they are ending the person don't have the job, you have to opt for here. So the question is very tricky. Please take care. Take care in this question. Be cautious. Read your question very carefully. Give me a thumbs up. If you got the concept, give me a thumbs up. So PSM, very easy subject. The only thing it is conceptual. You must understand the concept. You got my point? So that is the thing. So we are done with this chapter. Give me a minute. Let me come on the next chapter. Next chapter. We are done with the first chapter, health and disease. The next chapter I opted here, from which maximum question comes in your exam, is preventive obstetric, pediatrics and geriatrics. Quickly we will cover this chapter. So chapter by chapter we will do the rapid revision of the PSM. Okay, the first chapter we have done. The rapid revision of this chapter we will do it very quickly. So let's start it. So let's start with the obstetric cares. Can I start with the obstetric care? So in the obstetric care here, we will talk about 3 care. Antenatal care, intranatal care and postnatal care. So we are having 3 cares in the obstetric cares: antenatal, intranatal, postnatal. Antenatal care is given from the point of conception, as soon as the lady become pregnant. The point of conception, as soon as the lady conceive, the lady become pregnant, till the onset of delivery. This care is known as antenatal care. We give antenatal care. What are the components? What all care we give? I will explain you here. In intranatal care, the care is given at the time of delivery. At the time of delivery itself, we are giving care. What care we are giving at the time of delivery? I will explain you in intranatal care. And postnatal care, after delivery till 42 days of the delivery. After delivery till 42 days postpartum. We call this period as postpartum period. So in postpartum period, what care we are giving? That is postnatal. So we will discuss all three care one by one. Okay, chalo. So let's start with the first one, the antenatal care. As I told you, antenatal care is the care given to the mother during pregnancy. It is from the time of conception till the start of the labor, and it is basically given by female health worker in a primary health care center. So ideally 14 visits are required. Ideally, I'm saying the word ideally. 14 antenatal visits are required. The pregnant lady should come to the PHC or sub center 14 times throughout the pregnancy, ideally. But in the village, they are very, they are not very aware, and they are not very aware for their health. So they don't come for 14 times. So minimum According to Government of India, minimum 4 visits are required. So ideal, if they are asking ideal, go with the option 14. If they are asking for minimum, according to Government of India, according to GOI, Government of India, it is minimum 4 visits. So the first visit should be early registration. That is the first visit. Second visit should be 14 to 26 week of gestation. Third should be 28 to 34 week of gestation. And last visit 36 week onwards till delivery. So minimum 4 visits are required. Okay, now coming very commonly asked question, the calorie requirement. Calorie requirement of a pregnant lady, of a lactating lady. How much she should eat during pregnancy. You can understand this, how much the lady should eat extra during pregnancy if you first know the normal. How a female should eat normally. So first you should understand normal, non-pregnant lady. Then you must understand how much additional the lady should eat during pregnancy. So these are the NIN guidelines. I'm teaching you NIN ICMR latest 2020 guidelines, the calorie requirement. Okay. So the NIN guidelines I'm telling you. Listen. So calorie requirement depends on the type of the worker. Whether the worker is sedentary, moderate or intense. You can see. Sedentary worker is something who is sitting all the day on a chair, doing only mental work, no physical activity. That is sedentary. Moderate means little bit of physical activity, not much. And intense means, they are doing jogging, running and intense activity. So depending on that, the calorie requirement is there in males also, in females also. So males are only one type. Male is male. That's it. But females are of 3 types. This is non-pregnant female. This is pregnant female. This is lactating female. So females are of 3 types: non-pregnant, pregnant or lactating. But males cannot be pregnant. Males cannot be lactating. So male is male. So we divide the column in four portions. So this is male, this is non-pregnant female, this is pregnant female, this is lactating female. These 3 are female, this is male. Now for each of them, it's sedentary, moderate, heavy. Hana? So if you have to learn only one column, the remaining I will correlate. Okay, sedentary male required 2100 kilocalorie per day. 2100. Learn the first 2 digits. Don't go on the last 2 digits. 2100. Learn 2100. Moderate worker, male, required 2700. 27 kilocalorie, and a heavy intense worker required 34 kilocalorie. Learn these 3. For the female, the sedentary female required 1600. The moderate is same as that of sedentary male. The moderate female is same as that of sedentary, is 21. And the heavy worker female is same as that of moderate male, that is 27. I hope you got it. So you learn the male 2100, 2700, 3400. For female it's 1600. The remaining 2 are like this: 21 ka 21 and 27 ka 21. So a sedentary male is equal to moderate female. A moderate male is equal to heavy female. I hope you are getting it. So first you learn that. First of all, you have to learn that. Okay. Now if a female become pregnant, so which female? Now female can be this, can be this, can be this. Any female can become pregnant now, of course. The female who is pregnant, is it sedentary? Is it moderate? It is heavy worker. So first ask the routine of the female. Imagine there is a female, there is a lady who is coming to me and she's saying, doctor, I am pregnant. So how much I should eat extra? Should I eat extra? Yes, of course you should eat extra. How much kilocalorie should I eat extra? So first I should ask the female what type of worker you are. Are you a sedentary worker? You sit all the day, or you are a moderate worker? You do your day-to-day housework, housekeeping, or you are some intense like worker. So what type of worker you are? You are pregnant, but what type of worker? So whatever worker you are, you should take that calorie accordingly, additional 350 kilocalorie. So 1600 plus 350, 2100 plus 350, 2700 plus 350, whatever is the answer. Don't do the summation, you will do it on the spot. So additional 350 kilocalories required during pregnancy, that you have to learn. Additional 350 kilocalories required during pregnancy, during all 3 trimester. First trimester, second trimester, third trimester, it doesn't depend on trimester. Now during lactation, the female already delivered the baby. Okay, the baby is out, the female already delivered the newborn. Now the lady is lactating the newborn. Lactation means breastfeeding the newborn. So during first 6 months of breastfeeding, the newborn is completely depending on the mother. Okay, we don't do anything extra. We give exclusive breastfeeding. We recommend exclusive breastfeeding during the first 6 months. So the lady should eat additional 600, whatever is her daily requirement. So 1600 plus 600, 2100 plus 600, 2700 plus 600. Additional 600 during first 6 months of lactation. During the late 6 months of lactation, she should eat additional 520. So you get question on 350, 600 and 520. Please learn it by heart. I hope you got it. Give me a thumbs up if you got it. Yes. So please learn during pregnancy, during first 6 months of lactation. Why during later month of lactation it reduced? During first 6 months of lactation is additional 600. It is more even than pregnancy, because now she has to feed for herself and her baby. She is breastfeeding now. So she has to feed herself for herself also and for her baby also. So additional 600 is required. Later on, after 6 months, we start weaning in the baby. So we are giving extra food to the baby apart from the breastfeed. So breastfeeding requirement is little bit less. So that's why here additional 520 is there. So please learn that. I hope you got it. You get many questions on this 350, 600 and 520. These are all your ABCD option. Don't get confused. Okay. So calorie requirement according to NIN. Okay, National Institute of Nutrition. What is NIN? National Institute of Nutrition. It's in Hyderabad. These are the latest guidelines 2020. NIN guidelines. Okay, got my point. It is the calorie requirement. So the same calorie requirement during pregnancy, additional 350, and during first 6 months of lactation, additional 600. During later 6 months of lactation, additional 520. See the plus sign. See the plus means additional, है ना, सिर्फ 350 नहीं लेना है, 1600 या 2100 2700 तो लेना ही लेना है, उसके ऊपर इतना लेना है. It is additional. I mean, it's additional. You are getting my point. How much protein requirement is there? So this is the calorie requirement. We eat calorie in our diet. We eat protein in our diet. So additional protein is also required during pregnancy. How much? But before that, understand the normal. You can understand. You can understand in pregnancy only if you can understand normal. First, understand normal. So again, we have 4 categories. Male is male only, but females are of 3 types. This is non-pregnant female. This is pregnant female. This is lactating female. The 3 type of the female. All males require 54 gram protein in one day. It doesn't depend on the type of worker. There may be a sedentary worker, moderate worker, and it's a myth. You know, I have seen many boys, many teenage boys or many school going boys, they do gymming. They go to the gym. Gymming is very, common nowadays. They go to, and they think, ma'am, I go to the gym. That's why I eat additional protein. My gym trainer have told me, no, it's wrong. Whatever type of worker you are, whether it is sedentary, moderate or intense, the calorie requirement is different. You should eat additional calorie if you are an intense worker, you are doing gymming. The calorie requirement is different, but protein requirement is same. So gym trainer, ideally, if they are educated, they shouldn't train like that. Got my point? Protein requirement is same for all male, whether it is a sedentary worker, moderate worker or intense worker. It is for an adult male, it is 54 gram per 24 hour. Per 24 hour, including breakfast, lunch and dinner. It is 54 gram. That's it. No additional protein should be taken. Okay, if it is an intense worker even. Okay, for all females it's 46. For all females it's 46. It doesn't depend on the type of the worker, sedentary, moderate and intense. I repeat my words. During pregnancy, now there are 3 trimesters in pregnancy, first, second, third. During first trimester of pregnancy, no additional protein is required. Because during first trimester of pregnancy, organogenesis is not much. Okay, the conception is there. But organogenesis, the parts of the fetus is formed in the second and the third trimester. During first trimester, it's still 46. During the second trimester, 46 plus 9.5. Whatever is the answer. You can do the calculation 46 plus 9.5. It may be 55.5. 55. But don't learn that. Learn additional 9.5 grams per day. And during the third trimester, it's additional 22 because organogenesis is very high. So high protein requirement during the third trimester of pregnancy. So 46 plus 22, whatever is the answer. You can do the calculation. So 46 plus 9.5 and 46 plus 22. Okay, during second and third. During first trimester, plus 0. It's 46 only. During lactation, during the first 6 months of lactation, additional 17. And second 6 months of lactation, additional 13. So 46 plus 17, 46 plus 13. I hope you are getting it. So learn these terms. You get many questions on that. Please learn. So can we make a table, final table for that? So let's do for calorie also. And let's do for protein also. Okay, so males are only males. Okay, females are of 3 types. Let's write non-pregnant female. Okay, pregnant female. Okay, and lactating female. And these are males. Males are only males. Okay, chalo. So first we will do the calorie requirement and then we will do the protein requirement. Calorie requirement. For calorie requirement, whether the worker is sedentary or moderate or heavy worker, that's required. Okay, this is for calorie requirement. But for protein requirement, it doesn't matter. Okay, it doesn't matter. So we will do it. Chalo. So can you tell me for a sedentary male, moderate or heavy male, how much calories required? Can you tell me the answers? It's 2100, it's 2700 and 3400. You have to learn. Learn first 2 digits. That's more than sufficient. Here you have to learn 1600. Here 2100 will be like this. Okay. And 2700 will be like this. So you have to learn that. During pregnancy, whether it is first trimester, second trimester, third trimester. So I will write first, second, third. Hana, here also first, second, third. Here calorie requirement in all 3 is same. All 3 is same. It's additional 350 kilocalorie. Additional 350. And during lactation, it depends whether first 6 month or next 6 month. Okay, first 6 month में additional 600 is required and next 6 month में additional 520 is required. Kilocalorie per 24 hour. You have to learn that. Coming on the protein requirement. In the protein requirement, all males require 54 grams per 24 hour. All females require 46 grams per 24 hour. During the first trimester, additional 0. During the second trimester, additional 9.5, and during the third trimester, additional 22, apart from 46. Additional. During the first 6 months, of lactation and later 6 months of lactation. So during first 6 months of lactation, it's additional 17 and here additional 13. So please learn. You get many questions on that. Give me a thumbs up if you got it. So this is all about the nutrition. Nutrition wala chapter bhi yahan pe cover ho gaya. So that is the thing. Got it? Anyone have any confusion? Can we proceed ahead? Okay. So let's go ahead. Preventive services to the antenatal mother. Now we are talking about the antenatal services. Antenatal, intranatal and postnatal. So preventive services to the antenatal mothers. We are giving 7 preventive services to the antenatal mother at the sub-center and at the primary healthcare and CHC, PHC and CHC. Okay. The first of all, we will do lab investigation at the sub-center itself. Number 1, we will do UPT, urine pregnancy kit. It is known as Nishchay. With the help of Nishchay, it is free of cost provided to the lady. We will confirm the pregnancy. It is known as urine pregnancy kit, UPT kit. It is with the name of the Nishchay. Okay. We will do RDT test for the malaria. We will see the hemoglobin. We will see the urine dipstick for the albumin and sugar, and we will do HIV testing. That is done at the subcenter. Then we will refer the lady to the PHC or CHC or the first referral unit for doing the blood grouping, VDRL for syphilis, HIV, hepatitis S antigen, or random blood sugar. This is the investigation wala portion. Don't learn that. Then the third thing, we will provide iron and folic acid tablets free of cost. It is free of cost provided to the lady. Iron and folic acid tablet. So one tablet contains how much iron and how much folic acid? It is iron folic acid tablet. It is known as IFA. Iron folic acid tablet. One tablet contains 60 milligram of iron and 500 microgram of folic acid. Please learn that. 60 milligram. Please see, this is milligram and this is microgram. So 60 milligram of iron and 500 microgram of folic acid. This is the combination. You get question on that. Yes. So please learn. This is iron and folic acid tablet. So the tablet is started from day 1 of the 14th week till post delivery for the entire year. From the 14th week onwards, we start this tablet. If the hemoglobin is more than 11, 1 tablet has to be taken. If hemoglobin is less than 11, 2 tablets has to be taken for 1 year. That is provided free of cost, the 365 tablets. That is iron folic acid tablets. The next is immunization. We will give tetanus immunization to the lady. This immunization is given 0.5 ml intramuscular. It is given on the deltoid. You can see 0.5 ml intramuscular. 2 doses are given 1 month apart. The first dose should be given after 3rd month in the first trimester, and second is after 1st month, after 1 month of the first dose. That is the thing. We will do deworming once. We will give single dose of mebendazole. That is drug of choice. Albendazole is not given. And last, we will give the calcium tablets also. We will give twice a day, total 1 gram per day. Okay, we will give 2 tablets, 500 milligram, 500 milligram. 1 in the morning, 1 in the night. 2 tablets we will give. So total dose of 1 gram per day. We will give calcium. We again started from the 14th week of pregnancy till 6 month postpartum. Okay, so this is all free service. And we will make a card that is known as referral services. This is known as MCP card, Mother Child Protection Card. Mother Child Protection Card, this is the card. It is of 2 color. If the pregnancy is normal, we will make a green card. If the pregnancy is high risk, we will make a red card. The same card is of red color. So these are the services. These are the services we provide. Antenatal. I told you obstetric care is of 3 types: antenatal, intranatal and postnatal. In the antenatal, what services we are providing? We are doing the investigation at the subcenter. We are doing some investigation at the PSC. You have to learn what investigation at the subcenter, what investigation at the PSC. We are providing iron folic acid tablets. We are providing calcium tablets. Okay. We are doing the deworming. We are giving the tetanus vaccine, and we are making the MCP card, Mother Child Protection Card. So these are the services we are providing free of cost to a lady who is pregnant and coming to PSC. These are the antenatal services which are provided. Coming on the intranatal, at the time of the delivery, what do we do? What do we do? Of course, we help the lady for delivering the child. So we take care of clean for a safe delivery. For a safe delivery, we take care of the clean. We take care of 5 cleans. You get question on these 5 clean. What are the 5 clean? What are the 5 clean? There should be a clean delivery surface. So the lady will lie on a surface. So first you take a sterile new disposable sheet. You have to take that sheet and ask the lady to lie down on that sheet. So every time new sheet should be open, new plastic sheet, a clean plastic sheet on which the bed on which you will ask the lady to lie down for delivery. So clean surface should be there, number one. After that, clean the hands of the attendant, not of the pregnant lady, the birth attendant. Maybe it's a doctor, it's a nurse, it's a dai, it's a trained dai. So clean the hands with the soap and the clean water of the birth attendant. Number two, clean hands should be there of the birth attendant. Number three, once the delivery is done, the cord has to be cut with a blade. So every time a new sterile razor blade has to be taken. It should not be reused. A new sterile razor blade should be taken for cutting the cord. After cutting the cord, we have to tie the cord with a piece of the thread. So every time a clean piece of the thread, the sterile thread should be taken with which we will tie the cord. And number five, nothing has to be applied on the stump. Nothing has to be applied. In various religions, various cultures, some people apply honey on that, some apply cow dung on that. So because of the rituals and taboos, but nothing has to be applied, not even water, nothing has to be applied. So these are the five things: clean surface, clean hand, clean cut, clean tie, and clean stump. Please learn the five. Please learn the five cleans. What are the five clean? For clean surface, we use a sheet every time. For clean hands, we use soap and water. For clean cut, we use blade, a new razor blade every time. For clean tie, we use a new thread, sterile thread every time. And for clean stump, nothing has to be applied on the stump. So these are the five cleans. With the help of how we achieve these five cleans, I told you. Now finally, postnatal care. We are done with antenatal, intranatal. Now coming on the postnatal care. Can I come on the postnatal care? In the postnatal care, minimum 3 to 4 visits are required. If it's a home delivery, 4 visits are required. If it is an institutional delivery, only 3 visits are required. Because institutional delivery mein, the day the lady deliver, it is already in institute. Okay, so the first visit is on day 0. Day 0, the lady deliver. Second visit on day 3, third visit on day 7, and fourth visit, the last visit on day 42. Up to day 42, we consider partum, postpartum, from the day of delivery up to 42 days. So day 0, day 3, day 7, and day 42. The 4 visits are required if it's a home delivery. If it's an institutional delivery, day 0 visit is not there because it's already in hospital in an institute. So the remaining 3 visits are required. On second day, she is discharged. So 3 visits are required. The postnatal care. I hope you got it. Everyone give me a thumbs up. So I'm done with the obstetric cares, the antenatal, the intranatal, the postnatal. Now I'm coming on the infants. Okay. So what is the ideal weight of an infant? What is LBW? Low birth weight. The birth weight is the single most important criteria for looking the chances of survival of a newborn. Whether the newborn is going to survive or do not going to survive, it depends on the birth weight of the infant. Birth weight of the infant is the most important criteria that's going to decide the chances of survival of an infant. Okay, so chances of survival depends on the birth weight. What it depends on? It depends on birth weight. Say yes, got it. So, birth weight. What is LBW? What is VLBW? LBW is low birth weight. Low birth weight. VLBW is very low birth weight. This is low birth weight. This is very low. So if the birth weight is less than 2.5 kg, it's low birth weight. If the birth weight is less than 1.5 kg, it's very low birth weight. So low birth weight and very low birth weight infants, there are less chances of survival. There can be complication, and that's the thing. If a lady who smoked during pregnancy, in pregnancy, the lady shouldn't smoke. If a lady is smoking during pregnancy, the weight of the newborn is less than 170 grams as compared to normal. So 170 gram of weight is lost due to the smoking. So a lady shouldn't smoke during pregnancy. All these are your PYQs. Please learn. What is LBW? 2.5 kg. The cutoff. What is VLBW? The cutoff is 1.5 kg. Please learn that. Okay, I hope you got it. Now there are two types of LBW. What is LBW? LBW is a newborn whose birth weight is less than 2.5 kg. There are two causes of LBW or two types of LBW. Number one, preterm babies. Number two, small for date babies. Small for date babies is SFD. What do you mean by preterm babies? And what do you mean by SFD? In both of them, the birth weight is less than 2.5. I agree, but the reason is different. In both of them, the birth weight is less than 2.5 kg. I agree. But the reason is different. These are the two types of LBW. LBW is low birth weight baby. Low birth weight baby is a baby in which the newborn is having a birth weight less than 2.5 kg. You can see the newborn is having a birth weight less than 2.5 kg, but there are two causes. Number one, preterm. Number two, small for date. Let me explain you. Can you see this is uterus, the two uterus, and inside which the fetus is there. This is a fetus and the placenta. The inside the uterus, there is fetus. Now, please understand. In one, I will explain you the preterm. In other, I will explain you the SFD. Okay. Now, when is the term? Okay, now imagine this is 28 week of gestation, then 30 week of gestation, then 32, then 34, then 36. After 36, we expect the term, we expect the delivery anytime after 36 to 40 onwards. We expect the normal delivery. This is known as term. This is known as term delivery. Got my point? This is so when we take the weight of the baby at 28 week, the weight is less according to the 28. Then the weight will become little bit more according to the 30. Then it will be more. It will be more at 36 to 40. When there is term, we expect the weight of the baby should be more than 2.5 kg. When the baby time is to come out, this is term, baby. This is term. Imagine the baby is born before term, preterm baby. I'm explaining you preterm. The baby is born before time. Ideally, the baby should come out 36 to 40 week of gestation. This is known as term. Now, imagine the delivery is taking place at 34, 32, 30, 28 week, any week. It is before term. So the weight of the baby will be obviously less. The baby who is coming out, it is less than 2.5 kg. But the weight is according to the gestational age. It is corresponding to the gestational age. Whatever. Suppose the baby is born at 28 weeks. So the weight is according to 28 weeks. Suppose the baby is coming at 30 weeks. So the weight is according to the 30 weeks. So it is corresponding to the gestational age. So such LBW is known as preterm. I agree the weight is less than 2.5. I agree. But it is corresponding to the gestational age. Whatever gestational age the baby is coming out, corresponding to that the weight is there. This is known as preterm baby. Now see the second one. The second one I am telling you here is small for date baby. Naam mein matlab hai. The name itself indicates its meaning. Small for date. So here babies, whether they are coming preterm or term, or preterm or term, whenever they are coming, doesn't matter whether they are coming at 28 week or 30 week, 32 week, 34 week, 36 to 40 week, whenever they are coming out, they are also less than 2.5 kg, but their weight is less than the gestational age. It is not corresponding. If they are coming at 36, they should be 2.5, more than 2.5, but they are 10 percentile less than that. If they are coming at suppose 32, they are coming at 30. If they are coming at 28, so expect the weight should be according to 28, but the weight is less than 28 week of gestation. It is 10 percentile less. So they are small for date. Whether they are coming even at term, they are small for date. They are coming preterm also, they are small for date. So here the weight is not corresponding with the gestational age. It is less than the gestational age. Here the weight is corresponding to the gestational age. So after birth, now both of them are LBW. This is also less than 2.5. This is also less than 2.5. This one is known as preterm. This one is known as preterm. And this one is known as small for date. But here catch up is very fast. Catch up after birth, the catch up is very fast. They easily catch up. Here catch up is little bit slow, because here I can say IUGR is there, intrauterine growth retardation is there, because here the weight is not corresponding with the gestational age. It is less than 10 percentile of the gestational age. So intrauterine growth retardation is there. So catch up is slow. I hope you got it. These are the two types of LBW. Most common among them is preterm. So preterm and small for date are the two types of LBW. First, you understand what is LBW. You understand the two types of the LBW. These are the two types. The first one is the preterm. Here the problem is that baby is born too early. They are born before 37 week of gestation. They born too early. उनको बाहर आने की बहुत जल्दी है. But intrauterine growth is normal. Here the weight is corresponding to the gestational age. If they are born at 28 week, the weight is corresponding to the 28 week. They are born at 32 week, the weight is corresponding to the 30. But they are born before 37. So they are less than 2.5 kg. But here catch up is very fast. These are preterm. And the second is small for date. They are term or preterm, but weight doesn't correspond with the gestational age. Weight is less than 10 percentile of the gestational age. They have intrauterine growth retardation. Here catch up is slow. And 70% of LBWs are this. So we are done with LBW. How many of you got it? I taught you a topic that is LBW. Now I will teach you the treatment of the LBW. LBW is low birth weight baby. Any baby whose birth weight in India less than 2.5 kg, it is known as LBW. There is one more term we known as VLBW. That is very low birth weight baby. VLBW. If the birth weight is less than 1.5 kg, it is known as VLBW. The LBW or VLBW are of two types I told you. One is preterm LBW, preterm, and one is small for date. The main difference is that both of them are less than 2.5. That's why these are the types of LBW. Here also less than 2.5 kg. Here also less than 2.5 kg. I agree, but the cause is different. Here the baby is born preterm, but the gestational age, the weight is corresponding with the gestational age. It is corresponding to the gestational age. Whatever is the gestational age, the weight is corresponding with that. If the baby is born at 28, the weight is according to 28 week, like that. Here, the weight is not corresponding to the gestational age. Weight is less than by the 10 percentile of the gestational age. So these are small for date babies. And here IUGR is there. Intrauterine growth retardation is there. Here no IUGR is there. So 70% of the babies are SFD and 30% are preterm out of the total 100% LBW. So this is the percentage. Most common are IUGR. You got my point? And here catch-up is fast. Here catch-up is slow. So that's all about it. That's all about it. The type of the LBW. Now to treat LBW, the best way. Now LBWs are at high because the baby is very less in weight. The weight of the baby is less than 2.5 kg. The skin is not very much developed. The babies are at high risk of hypothermia and the babies are at high risk of infection because they are very low birth weight, and the complication after birth can occur and there are less chances of survival. The baby can die also. The survival will be, it can be critical. So we have to increase the weight of the baby very fast, and low birth weight, we have to make the weight at least 2.5 kg very fast. How we can do so? There are two ways. Either keep the baby in incubator. Okay, incubators are present in NICU, neonatal ICU, but they are very costly and not everyone can afford the NICU. One day charges of NICU are very high. So the best incubator is the mother itself. So we discovered a technique. The name of the technique is kangaroo mother care. What is kangaroo mother care? It was introduced first time in Colombia by a scientist, a person, Dr. Hector Martinez and Adzarre. You have to see the name of the scientist so that in the options you can identify them. So these are the scientists who discovered this care, that is kangaroo mother care, where the low birth weight baby has to be kept between the two breasts of the mother, naked. Skin to skin contact. So there should be skin to skin contact between the baby and the mother, the skin of the mother between her breast, between the two breasts, so that the baby will get the warmth and baby will not get the infection and baby will gain the weight very fast. It is the best natural incubator, and here no costing is required, and we can discharge the mother after training and there will be no chances of cross infection in the hospital itself. So here the weight gain has to be at least 2 kg. Up to the 2 kg, this care has to be given, and this care has to be given 24-hour mother has to keep the baby between her two breasts and skin to skin touch. Not only mother, any of the family member, even the father, grandmother, others can also give this care. It should be skin to skin, naked. That's it. That's like that. There are 3 advantages of kangaroo mother care. It is known as KMC, kangaroo mother care. 3 advantages. Number 1, it prevents the baby from hypothermia because of skin to skin contact. That temperature is getting transferred from the mother to the baby, so baby will not get hypothermia. Number 1, we are reducing the chances of hypothermia by providing warmth to the baby. Number 2, baby is very close to the breast, so whenever the baby is hungry, baby is crying, mother can offer the breast milk. So we are promoting the growth by exclusive breastfeeding. Baby is close to the breast and every time mother can offer the breastfeeding. Number 2. And number 3, we are protecting the baby from the infection by preventing cross infection. We can easily discharge the mother as well as baby after training the mother and the family members. If we keep the baby in the incubator, so there are chances of cross infection. So these are the 3 advantages of KMC. Now coming on the feeding of the infant. Can I come on the feeding of the infant? Now you tell me which milk is best for the baby. Is it human milk? I mean the breast milk. The breast milk is best, or is it cow's milk? Is it cow's milk which is best? You tell me which milk. Now there is a taboo, there is a myth in Indian society. I have seen the grandmothers say that cow's milk is more healthy than the human milk, and they start feeding the newborn on the cow's milk. You tell me which is best. You compare first before saying anything. You just compare. So compare the lactose in both of them. Don't learn the values, compare the values. So you can see in human milk lactose is more, and in human milk iron is more. 2 things are more in human milk. The mother milk, 2 things are more. The lactose, that is carbohydrate, and the iron. Apart from that, protein, fat, and calcium, everything is more in the cow's milk. Everything. So which milk is better? I agree that protein, fat, and calcium is more in the cow's milk. But cow's milk is for calf. And human milk is for human baby. Human milk is for human baby. I mean, if you give the cow's milk to human baby intestine cannot digest it. I agree it is having more protein, लेकिन इतना protein वो digest ही नहीं कर पाएगा. उसका intestine immature है. So the cow's intestine, the calf intestine can digest it, but human baby intestine cannot digest such a high level of protein, high level of fat. So God has given everything very judgmental. Whatever God has constituted, it's very judgmental. So cow's milk is for the calf, and human milk is for the human baby. So I agree the energy is more in the cow milk. I agree the grannies are not wrong. The grandmothers are right. The cow's milk is more nutritious depending on the protein, fat, and total energy and depending on the calcium. I agree, but that is not beneficial for the human baby. I mean to say, it is more energetic, but it is not beneficial for human baby because human baby cannot digest that. That is the point. So please learn lactose and iron are more in mother milk, and protein, fat, calcium and total energy is more in cow milk. You have to learn that. I hope you got the reason also. I agree the energy is more in cow milk, but that shouldn't be given to newborn because newborn cannot digest it. अति सर्वत्र वर्जते, तुमने ज्यादा दे दिया तो digest ही नहीं कर पाएगा. Best milk for the human baby is human milk only. The mother's milk, the breast milk. So that is the summary. I hope you got it. Now four milks are available, है ना? Buffalo milk, goat milk, cow milk and mother milk, the human milk. So if we compare the fat, protein, energy and lactose in these four, what is the sequence? It is a particular sequence you have to learn. So only for lactose the sequence will be different. For remaining all three, fat, protein and energy, the sequence is buffalo followed by goat, followed by cow, followed by human. Make some mnemonic. You can make some mnemonic. Maximum is in buffalo followed by goat, followed by cow. Cow is on third number. So it's a myth. You know, my granny says that cow's milk is more nutritious than buffalo. No, the granny is wrong. Buffalo milk is more nutritious than cow. The science says that. Huh? So maximum fat is present in buffalo. Maximum protein is present in buffalo. Maximum energy is present in buffalo. Followed by goat, followed by cow and followed by human milk. So in this sequence, but only for lactose, human will be the first. You can see, put the human as the first. The remaining three will be the same sequence. Got my point? So you can make some mnemonic. B, G, C, H. Make some mnemonic. B, G, C, H. You got my point? So for protein, for fat, and for total energy, what is the sequence? And for carbohydrate or lactose. Carbohydrate and lactose is one and the same thing. What is the sequence? Here the sequence is B, G, C, H. Got my point? Here H will be on one. H followed by BGC. So human will be number one. It's like that. Got my point? So you get question on that. Give me a thumbs up. People, why don't you interact? Only 1-2 persons are saying constantly and the others are silent. Why? You are getting or you are not getting? So say something. Now you can make some mnemonic. If you have some mnemonic in your mind, you can say. One of the mnemonic in my mind, let me share. Bhai Goa chalte hain. Bhai Goa chalte hain. If you have some English version, English mnemonic for that, kindly let me know so I can share with others. है ना? यहाँ पे H is in the first. And remaining three are the same. Got my point? So please make some mnemonic and learn that. Learn the sequence. Got my point? Chalo. So coming on the breastfeeding, few important points on the breastfeeding. Breastfeeding is a beautiful process involving the mother and the newborn. And breastfeeding should be started within half an hour after vaginal delivery. And it should be started within 4 hours after cesarean section. These are the guidelines. Okay? Because in cesarean section, the anesthesia is given to the mother. Maybe the mother is in the recovery room for few hours after the anesthesia. So within 4 hours, it should be started. But after vaginal delivery, it should be started within 30 minutes. The breastfeeding. These are the guidelines when it should be started. Okay. Notes I will provide, Dr. Sudan. You if you want to write, it's okay. But otherwise, if you want me, I can share the PDF also. Okay. Anyways, chalo. So breastfeeding. It should be started within half an hour after normal delivery and within 4 hours of cesarean section. Learn the timelines. So these are the guidelines given. Now, whenever the breastfeeding is started, as soon as, imagine you are hungry and imagine simultaneously you are thirsty. Hana? So what do you want first? You want water or you want food first? So you want to satisfy your thirst first or you want to satisfy your hunger first? Imagine there may be situation, you may be feeling both hungry as well as thirsty. So of course we want to satisfy thirst first. So first we want water and later on we want the food. So same applied for the baby also. We don't even give water to a newborn up to 6 months exclusive breastfeed. So water is also provided in the breast milk. So as soon as the newborn starts sucking the nipple of the mother, as soon as the newborn is started sucking the nipple, so first few ml of milk is very thin, it's watery and it's sweet, containing the lactose. That is known as fore milk. That is to satisfy the thirst of the baby. So fore milk is rich in sugar and water. It's a sweet water to satisfy the thirst of the baby. It's mineral water. The God is providing mineral water to the baby. So mineral, vitamin, sugar with water. It's very thin. But later on, after few ml, the baby keep on sucking. The later ml which is coming, it's very thick. It contains the fat, abundant of fat to satisfy the hunger of the baby. And that is known as hind milk. That's why we always suggest the mother, whenever she is starting breastfeeding her baby, at least she should continue for 30 minutes. So that first 10 minutes, The fore milk will come, and the later 15-20 minutes the hind milk will come. So the baby's thirst as well as baby hunger both are satisfied. If the mother only keep on breastfeeding only for 10 minutes every time, so thirst is satisfied but hunger will not be satisfied. So again and again the baby will cry. That's why we advise the new mothers, the primer mothers, that keep breastfeeding. If you are breastfeeding the baby, at least do it for 30 to 40 minutes so that thirst and hunger both are satisfied. So fore milk followed by hind milk. I hope you got this concept. Okay, now storage of the milk. We can do the storage of the breast milk also. Okay, now there is a mother who is a working. Imagine she is a working lady. She's a working, and immediately after the delivery, next few days, next 1 month, or after the delivery, when she's feeling well, she want to join her job. But we are saying we have to give newborn exclusive breastfeed for the 6 month. So it is not necessary the mother may take a leave for the 6 month and sitting at the home and just breastfeeding her baby every 2 hours or every 3 hours. It's not possible. Some mothers are working, some are housewife, but some are working. She want to resume her job. So what to do? And she want to give exclusive breastfeed to her baby also every 2 hour, every 3 hour. What to do now? So she can express her milk. The pumps are available. With the help of the pump, she can express the milk and keep it. And some of the caretaker at the home later on, when the baby is hungry, can feed it with the help of the spoon. So that is known as expressed milk. In that case, we have to store the breast milk. Once the breast milk is out of the breast, with the help of the pump, she can express it in a container, in a sterile container, in a bottle. She can keep in a sterile container. She can keep, and that can be stored. If at room temperature we are storing, it can be stored for the 10 hours. For the 10 hours, that can be stored well without any contamination. And any of the caretaker, the grandmother, any of the granny or any of the nanny, the father, whosoever is available, can feed the baby later on if the mother is not available. Number one. And number two, if it is kept in refrigerator. So this is refrigerator, this is freezer. I am saying we are keeping the milk in refrigerator, that is 2 to 8 degree. Okay, we can secure it for 24 hours. If the mother is not available for next 24 hours, she can express a lot of the milk and keep it in the refrigerator, and the caretaker later on can feed the baby. If we are keeping it in the freezer at minus 20 degree, if we are keeping it in freezer for minus 20, we can store it for 3 months. So nowadays, like the blood bank, the breast milk banks are also available in some cities. Breast milk banks in some metro cities in India, the breast milk banks are available, where breast milk is available paid, like the blood bank. It is available paid. So the unfortunate infants, unfortunate newborns whose mothers are not there, whose mothers die immediately after the birth, or mother gets separated from the baby due to some any condition, the baby do not have the mother. For such babies, we can purchase the milk from the breast milk bank. And the breast milk bank, they store the breast milk at minus 20 degree. So some of the mothers who have additional breast milk, apart from feeding their baby, they can give it to the breast milk bank, and the breast milk bank will keep its storage in the refrigerator, in the freezer, for the 3 months. And for the 3 months that can be used. So learn the temperature ultimately. At room temperature, for how much time it can be stored? At 2 to 8 degree, how much time it can be stored? At minus 20 degree, for how much time it can be stored? These are your 3 PYQs. Please learn that. Here it can be stored for 10 hours. Here it can be stored for 24 hours. And here it can be stored for 3 months. Please learn the summary. Storage of breast milk. Give me a thumbs up if you got it. This is storage of breast milk. Can we go ahead? The next thing here is the assessment of the physical growth of a child. Now let's talk about a child. Okay. We have to look for 5 things in a child, whether to see whether the child is growing or not growing. 5 things. We have to monitor the weight, monitor the height, monitor the head circumference, chest circumference, and mid-arm circumference. You get many PYQs on this. Please concentrate. So first thing is the weight. So weight is measured on an instrument. This instrument is known as Salter scale. For small babies, it's like that. If you want to measure the weight, make the baby naked. Even no nappy should be there. No knicker, no nappy. The baby should be completely naked so that we can accurately measure the weight. This instrument is known as Salter scale. This is for small babies. For big babies, the Salter scale, the same Salter scale is like that. It's like a jhula. Hana, we put the baby in that. Hana, and here there is a scale that will measure the weight and give. So this is also Salter scale. This is also Salter scale. You can see. It should be, the birth weight should be measured within first hour. Within first hour. As soon as the newborn is born, within first hour we measure the weight. It is known as birth weight. Birth weight is the most important criteria to decide the survival of the newborn. Birth weight. Ideally, the average birth weight in India is 2.8 kg. Less than 2.5 kg is LBW. Less than 1.5 kg is VLBW. And average weight in India is 2.8 kg. Okay. As soon as the newborn is born, imagine the birth weight is 3 kg. Okay, the baby is healthy. Baby is not LBW, VLBW. Baby is healthy. Okay, and baby is having 3 kg. So in the next 10 days, baby will lose weight. Baby will lose weight. 10% of the weight is lost. In the next 10 days, it's normal. It's normal. So if the baby is 3 kg, 300 grams is lost. 300 grams is lost. So baby will become 2700. And at the 10th day, again 3 kg. So birth weight is equal to the 10 day. So if you make the graph will be like this. So birth weight, this is the 0. So this is the birth weight. So birth weight 1 kg, 2 kg, 3 kg, 4, 5, 6. For example, the birth weight is 3 kg. 1, 2, 3. So this is the birth weight. So initially the weight drops 10%. Then again rise and again first become the birth weight on the 10th day. So this is the 10th day. On the 10th day, it is same as that of birth weight. And after that, it constantly rises. It constantly rises. So you should know this dip. So 10% fall occurs in the first 10 days. And on the 10th day, it again become equal to the birth weight. So this is a rule. It is normal. So on the 10th day, the birth weight is equal to the 10th day. And 10% fall is there. So that is about the weight. Coming on the height or length. Okay. Up to 2 years, we call it length. And after 2 years, we call it height. Because up to 2 years, baby can't stand properly. So in lying down position, it is known as length. But in standing position, it's known as height. After 2 years, the baby can stand. The babies can stand after 2 years. So after 2 years, I will call it height. Before 2 years, when it is lying down, I will call it length. So length or height, one and the same. So there is another instrument required. The name of the instrument here is infantometer. Infantometer. Here 2 people are required. Here only 1 people is required to take the weight. But for height, 2 people are required. So so you can see there is a scale and there are 2 slabs. So one slab is kept at the head and another slab kept at the feet, but knees should be straight. So one person should keep the slab at the head, another person should straighten the knee and keep another slab at the foot, and then measure the length or the height. So this is infantometer. You can get image based question. This is Salter scale. This is infantometer. Please, you can get the image based questions on that. Okay. So this is what you have to learn. Okay. So please learn the height. Height can be taken up to the first 3 days. The average birth height is 50 centimeter. Birth weight is 2.8 kg. Birth height is 50 centimeter. And in 1 year, additionally 25 centimeter is gained. So it will become 75 centimeter. So you have to learn about the height. Now we have seen the weight, we have seen the height. Very important question is malnutrition, acute and chronic malnutrition. Most of the students have confusion here. What is acute malnutrition? What is chronic malnutrition? What is acute and chronic malnutrition? There are 3 types of malnutrition: acute, chronic, acute and chronic. Please pay attention. So based on the weight and the height, we will decide the malnutrition. Which malnutrition is there? Is it acute? Is it chronic? Or is it acute on chronic? Let me tell you. So let me write acute malnutrition, chronic malnutrition, and acute on chronic malnutrition. Let me explain. First, you understand the meaning. Rather than mugging up, understand the meaning. Imagine a newborn. Imagine a child, not a newborn. Imagine a child who is born in a well-to-do family. The parents are feeding the child very well. The child is having good weight, average height gain. Everything is good. Unfortunately, the child got kidnapped. Oh my God. Or there is some tragedy in the family. There is some acute illness in the family. There is some emergency in the family. And since last 1 to 2 weeks, the child is not fed well. Before that, the child was good. The child was fed well. The child was given good food. But within the last 1-2 weeks, due to the kidnapping or some emergency, the child is not given the food. So it is acute malnutrition. It is acute. It is known as acute. Imagine a child who is born in a poor family. From childhood only, from the newborn only. Okay. So child is not given the food from the childhood only. Okay. From the first day only, the child is not given very good nutrition. So it is chronic malnutrition. This one is acute. This one is chronic. And there can be acute or chronic. There is a chronic malnutrition on which acute episode occur. Acute and chronic. First, you understand the meaning. Now, if you don't give the food for the 1-2 weeks, the weight will not gain. Weight will fall. Height will not fall. Weight will not fall. But chronically, if you don't give the food to the child, the height will not gain. Chronically. If acutely, if you don't give food to the child, the weight will fall. Chronically, from childhood only, if you don't give good food to the child, the height gain will not be good. You got my point? Please understand. So in acute malnutrition, the weight is affected. In chronic malnutrition, the height is affected. Here, basically, weight is less than the corresponding height. Whatever is the height, the weight is less as compared to that. In acute malnutrition. Here, the height is less as compared to the age. as compared to the age, the height is less. Height gain is not as much as it should be at that particular age. So here height is less as compared to age. In acute and chronic, divide the two. Divide the two. Acute upon chronic, divide the two. Can you divide this upon this? Can you do so? So do so. Now what is acute? Weight upon height. And what is chronic? Chronic is height upon age. Height upon age. So height cancel. So it is weight upon age. So weight upon age is acute and chronic. At least I tried my best. I don't know whether you got it or you didn't got it, but I tried my best. So these are the three type of malnutrition. Say yes if you got it. So low weight for height. Weight for height is acute. Height for age. Low height for age is chronic. And height cancel. So weight for age. Low weight for age is acute or chronic. How many of you got it? Acute malnutrition, also known as emaciation. Emaciation. Chronic malnutrition is known as stunning or dwarfing. And acute or chronic is known as underweight. People give me a thumbs up now if you got it. Whether you are listening or not listening, I am not getting it. How I come to know that whether you got it or you can see me, you can see and you can hear me, you can see my expression, but I can't see you. What I can see you is the chat box. That's it. This is the chat box. So kindly keep interacting whether you got it, you didn't got it. At least give a thumbs up so that I came to know, give a gesture that you got it. So this is the three type of malnutrition. What is the three type of malnutrition? There are three type of malnutrition. Acute malnutrition, you very frequently get question on that. Chronic malnutrition and acute on chronic malnutrition. These are the three type of malnutrition I taught you. So in acute malnutrition, first of all, acute malnutrition also known as emaciation. Chronic malnutrition also known as stunning or dwarfing. Okay. And acute and chronic is known as undernutrition, underweight. So please understand the other names. And after that, tell me the formula. Here, weight is affected because acutely the food is not given. The child got kidnapped. Initially, the weight was good, but now the weight is less. Here, height gain is not there because child is poor. From the childhood only, the child is not given the food. So height gain is not good. Okay, here weight is affected. Here height is affected. The first thing. Here weight is less as compared to height. Here height is less as compared to age. Cancel height. It will be weight upon age. So this is how you have to learn, people. This is how you have to learn. In the option, you will get this option, this option, this option. If you don't have the concept, you will be highly confused. If they ask for this, go with this. They ask for this, go with this. They ask for this, go with this. Like that. So concept should be clear. So the three type of the malnutrition. So we are done with weight. We are done with height. Based on weight and height, we are done with malnutrition. Coming on the third thing. Weight ho gaya, height ho gaya. The third thing is the head circumference. So we have to take the head circumference. Where has to be taken? Here. What is the level? The level is the occiput. Here we have occiput now. So at the level of the occiput, we measure the head circumference. We measure the head circumference at occiput frontal bone. This is my frontal bone. This is my occiput. So at this level, I will mark the frontal bone. I will mark the occiput and I will measure it here. So this is the head circumference, occiputo-frontal bone. Okay. So at birth, it is 35 centimeter. At birth, please learn. At birth. So at birth, the weight is 2.8 kg. Average weight in India, I'm telling you. The height is 50 centimeter and the head circumference is 35 centimeter. Please learn the values at birth. The remaining you will see in pediatrics, that how it increases with age. In pediatrics, you will learn in neonatology. Yes or no? Here also I have given the charts if you wish. Anyways, at birth. After that, it keeps on increasing. At 12 years, it becomes 52 and become constant. So if you measure mine, it's 52. Almost it's 52. After 12 years, it's constant. So maximum it is 52. At 12 years, it is gaining 52 and it is constant after that. After 12 years, it don't increase. This is about the head circumference. Coming on the next, chest circumference. We have to measure the chest circumference level. The chest circumference has to be measured at the level of the nipples. At the level of the nipples in a child. At the level of the nipples. First thing, it has to be measured at the level of the nipple. First say the level. Okay. What is the measurement? It is 3 centimeter less than the head circumference. What is head circumference? It's 35. 3 centimeter less than that. It's 32. At birth, it's 32 centimeter. At birth, the chest circumference is less than the head. The head is more. Can you see this diagram? You can see head is 35, but the chest is 32 only. At 1 year, they become equal. And after that, the chest is more and head is less. You can see in adults. In adults, you can see head is less, but the chest is more. After 1 year, the exchange takes place. So before 1 year, the chest circumference is more. Head circumference is more. Chest is less. At 1 year, they become equal. At 9 months to 1 year, they become equal. It's a p-value. And after that, it's exchange. And it is measured at the level of the nipple. The last one, the fifth one, is mid-arm circumference. Mid-arm circumference. Where to measure? Here, 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 here. Where to measure? The mid-arm circumference कहाँ पे लेना है? पूरे arm में. Where? So, you know, you have scapula. In the scapula, you have an acromial process here. Acromial process. So mark the acromial process. And you have the ulna bone. For the ulna bone, we have an olecranon process here. So mark the olecranon. So mark the acromial and olecranon and take the distance and take the midpoint. That is mid-arm circumference. So here we are taking the acromial process. And here we are taking the olecranon process. Olecranon process, and we are taking the midpoint of that. That is mid-arm circumference. Learn the level. The level is important. So acromial process or olecranon process का center है. It's the center of these two processes. So this is known as mid-arm circumference. It is measured with a simple tape. This is measured with a simple inch tape. You have seen inch tape. It is also measured with a simple inch tape. No special tape. So here simple inch tape. Here also simple inch tape. But for mid-arm circumference, we have a special tape that is known as Shakir's tape. That is Shakir's tape. Okay, so here what is the normal value? What is the normal value? The normal value should be more than 13.5 centimeter. The normal value should be more than 13.5. 12.5 to 13.5 is moderate malnutrition, but less than 12.5 is severe malnutrition. You know, this is very thin. Less than 12.5, severe malnourished. Okay, so Shakir tape. What is Shakir tape? This is Shakir tape. In the Shakir tape, we have three colors. The three colors of a signal. You know, in the signal, we have three colors, red, yellow, and green. The same three colors. So up to 1 centimeter or 0 centimeter till 12.5 it's red. 12.5 to 13.5 it's yellow, and more than 13.5 it's green. So because it is not measured by the doctors, being a doctor I can educate you, you all have a good IQ and you can understand that, but you know, we measure it with the, you know, Anganwadi worker, Asha worker, female health worker, male, they are doing this. So sometimes we cannot explain them whether it is coming less than 12.5 or between 12.5 to 13.5 or more than 13.5. So we have done the color coding. So we just ask them to see the color, whether it is coming in red zone. If it is coming in red zone, it's severe malnutrition. If it is coming in yellow zone, it's moderate malnutrition. If it is coming in green zone, it's normal. So they just mention the color. Is it red? See, in this child it's red. It can be red, yellow, or green. Red means severe malnutrition, yellow means moderate malnutrition, and green means normal. So that is Shakir tape. Shakir tape is simple inch tape, only color coding is done. So please see the color coding. The three colors are there. This is Shakir tape. You can see 0 centimeter till 12.5 it's red, 12.5 to 13.5 it's yellow, and 13.5 onwards it's green. I hope you all got it. Say yes. Huh? Okay, can we go ahead? Okay, chalo. So this is Shakir's tape. The next thing is the growth chart. Let's come on the next thing. The next thing is the growth chart. Growth chart were discovered by a scientist. The name of the scientist is David Morley. David Morley have discovered the growth chart. These are modified by WHO. You get a question on David Morley. These are modified by WHO. It is a visible display of child's physical growth and development. Okay, so it is the best way to see the child growth. So it is discovered by David Morley. These are the growth chart. Let me explain you two types of growth chart. One is WHO growth chart and one is recommended by Government of India. The growth chart which were recommended by Government of India. So first let me explain you the WHO growth chart. In WHO growth chart we have only two lines. Can you see the two lines here? We have only two lines in WHO growth chart. The lower and the upper. Here the lower reference is the 3rd percentile for the girls and the upper is the 50th percentile for the boys. Please learn. So this is the 3rd percentile for the girls and this is the 50th percentile for the boys. This is 3rd percentile for girl and this is 50th percentile for the boys. So please learn the lower and the upper reference. So child growth should fall between the two. It is known as road to health. This road is known as road to health. It should be parallel like that. It should not be static for the 3 months and it should not deteriorate. It should not fall. If it is static for the 3 months constantly, the weight is not increasing for the 3 months constantly, or it is falling, it's a red alert. It's a red alert. So on every visit, when the child is going to the doctor, to the pediatrician mark the weight with the age. So this axis contain the weight and this axis contain the age. So depending on the child, so this is birth weight, this is at 1 month, this is 2 months, this is 3 months, this is 4 months. So child is gaining the weight properly, this is road to health. If the child is not gaining the weight for the 3 months or it is falling, it is a red alert. It is an earliest indicator. It is the child is malnourished and we should do something. So this is WHO growth chart. Learn the two reference. The lower is the 3rd percentile for girls and upper is the 50th percentile of boys, 50th percentile, and the distance between the two is road to health. So child's growth should be in the road to health. I hope you got it. I hope you got it. But the growth chart, which is recommended by Government of India, having 4 lines, not 2. It is having 4 lines. What are the 4 lines? The uppermost line, you can see it is the 80th percentile of the median. It is the 80th percentile of the median. After that, there is 70th percentile of the median, then 60th percentile of the median, then 50th percentile of the median. Okay, so these are the 4. So ideally, the child should be above all. The child should be above all. है ना? ये 100 percentile है. Okay, this is 80, this is 70, this is 60, और यहाँ पे एक और बना लो. You can make one more here. This one is 50. So child growth should be above all, like here. Okay, here you can see the child growth is like here. If the child growth is between these two, it's grade 1 malnutrition. If it is between these two, it's grade 2 malnutrition. If it is between these two, it's grade 3, and below that it's grade 4. So we can do the grading in the growth chart given by Government of India. In the growth chart given by Government of India, we can grade, it is grade 1, grade 2, grade 3, grade 4. First degree malnutrition, second degree, third degree, or fourth degree malnutrition, depending. I hope you got it. I hope so. Let me compare the two growth chart. So this is WHO growth chart we are drawing here, and this is the growth chart given by Government of India, recommended by Government of India we are drawing here. This is WHO growth chart. This is the growth chart recommended by Government of India. So here we will draw only 2 lines, and here we will try to draw the 4 lines. 1, 2, 3, 4. So let me write down the reference. Here the lower is the 3rd percentile for girls, and upper is the 50th percentile for the boys. You can see, and the growth of the child should be between this, like this. It is known as road to health. It is known as road to health. Here it should be 80th percent of the median, 70th percent, 60% and 50%. So the child should be ideally above all these. This is normal. Here this is normal. If the child is here, it is grade 1 malnutrition. This is grade 2 malnutrition. This is grade 3 malnutrition, and below that it's grade 4 malnutrition. It's like that. So here we can do the grading. So these are the growth charts. In both of them, here we take the age of the child on the x-axis. On y-axis, we are taking the weight of the child. So it's a longitudinal monitoring of the growth, and it is known as growth chart. I hope you all got it. I hope you all got it. Anyone having any confusion till now? Anyone have any confusion till now? Can we go ahead? You want me to teach you more topics like that? Just a second. So let me come on the next thing. Just a second. The next most important topic for your exams. The next most important topic for your exams, I would like to take some topics from the nutrition. Okay, some topics from the nutrition. Okay, so let's come on the next chapter. Okay, we are taking the ultra important topics of all the chapters. Here, in your nutrition, 3 macronutrients are there: carbohydrates, fats, and proteins. These are the 3 macronutrients in our diet we eat. Okay, so 1 gram of carbohydrate give 4 kilocalorie. 1 gram of protein also give 4 kilocalorie. 1 gram of fat give 9 kilocalorie. If I'm eating 1 gram of carb, how much energy I get? If I eat 1 gram of protein, how much energy I get? If I eat 1 gram of fat, how much energy do I get? So 1 gram of carbohydrate give 4 kilocalorie. 1 gram of protein also give 4 kilocalorie, but 1 gram of fat give 9 kilocalorie. First of all, you learn that these are the 3 macronutrients in our diet. The 3 macronutrients in our diet. Okay, now let me tell you a balanced diet. What is a balanced diet? This is the healthy plate model given by NIN ICMR. Healthy plate model. It should be a healthy plate model. What do you mean by healthy plate model? What is balanced diet? A balanced diet is a diet. I already told you the calorie requirement in one day now. So a balanced diet is diet. For example, I told you the calorie requirement. If you are attending the session from the beginning, you may be knowing that I told you for males, for non-pregnant females, for pregnant females, and for lactating females. I told you whether the person is sedentary, moderate, or heavy worker. Whether the person is sedentary, moderate, or heavy. For example, I am coming in moderate non-pregnant female. So my energy requirement is 2100 kilocalorie. You can calculate for your own. If you are a male, you are a non-pregnant female, pregnant female, or lactating female, depending on the person who is listening. You want to calculate your calorie requirement. First of all, see your calorie requirement. This table we have already discussed. I am talking about this table. So whether the person is sedentary, moderate, or intense finance worker, first you decide in which category you are coming. You just sitting and studying whole day, or you do a little bit activity, or you do a intense jogging, gymming like that. So first you decide your category, you know your gender. So is it male? Are you a non-pregnant female, pregnant female, or lactating female? First you see your calorie requirement. For example, for me, I'm coming in this category, a moderate female who is non-pregnant. My calorie requirement is 2100 in one day. I should eat that. I should eat that. So what should I eat? I can get this by eating carbohydrate. I can get this by eating protein. I can get this by eating fat. Shall I eat only carbohydrate? Shall I eat only protein? Shall I eat only fat? I want 2100. No. So 2100 मुझे किसी से भी, no, I should eat all three. That is balanced diet. That is balanced diet. So out of the 2100, for me it is 2100. For you, you can calculate your own. Okay. For me it is 2100. The 10 to 15% of this 2100 I should get from the protein. 15 to 30% of this 2100 I should get from the fats, and remaining 50 to 70% of this 2100 I should get from the carbohydrates. Such a diet is balanced diet. So I should not eat only protein. I should not eat only carbs. I should not eat only fat. That will be unhealthy. I should eat a mixture of the three. I should eat a mixture of the three so that I can get 2100 in this proportion. So whatever is your calorie requirement, for me it is 2100. I'm a non-pregnant female like that. Okay. So whatever is your calorie requirement, you can split it into three portions. So the total calorie requirement, whatever is the total calorie requirement, out of that 15 to 20% should be obtained from the protein. 15 to 20%. Okay. I'm sorry. 10 to 15% should be obtained from the protein. 15 to 30% should be obtained from the fat, and remaining, that is 60 to 70%, should be obtained from the carbs. This is known as balanced diet. Please learn balanced diet. Okay, balanced diet. So this is the calorie requirement. Okay, I will take all these topics. All these topics are with me, but it will take time. One by one, I am taking the chapters and trying to finish it. We are having total important 15 main chapters in entire PSM. We will try to take all of them one by one and try to crush it. If required, we will schedule one more session if at all required and you people want it. I mean, it depends on you. Okay, anyways. The next thing is a reference Indian male and reference Indian female. You get questions on that. Who is a reference Indian male? Who is a reference Indian female? There are 5 criteria for both of them. So learn the 5 criteria. What is the age for both of them? What is the weight for both of them? What is the height for both of them? What is the BMI and what is the others? 5 criteria for reference Indian male, 5 criteria for reference Indian female. Learn them. So age is same in both of them. Age is same in both of them. It's 20 to 40 years. Rather than 20 to 40, reduce one year. 20 minus 1, 40 minus 1. Say 19 to 39. 19 to 39 years and 19 to 39 years. So age is same in both of them. 19 to 39 years. Weight is more in male. So reference Indian male का weight is 65 kg and reference Indian female का weight is 55 kg. So it is more in male. Height is also more in female. You know, males are little bit taller as compared to females, and weight is also little bit more than females. So male is 65 kg, female is 55 kg. That is regarding the weight. Regarding the height, the male is 1.77 meter. It is in meter. Okay. And female is 1.62 meter. If you say in centimeter, 177 and 162. Okay. 1.77 and 1.62. You have to learn. This is 1.77 meters and this is 1.62 meters. You have to learn. So height is also more in males, but BMI is more in females. BMI is more in females. Okay. So according to BMI, both of them are 20 point. Here 20.75, here 20.95. That is the BMI. And 5th criteria is same for both of them. Both of them should be free of disease. They should be active for the work. They should work for 8 hours. They should sleep for 8 hours and they should do 2 hours of recreation. So these are the criteria same for both. So can you tell me the definition of reference Indian male and reference Indian female? Can you tell me the criteria? Tell me the criteria for age, criteria for weight, criteria for height, criteria for BMI, and criteria for others. So start with the age. Age is same in both of them. Weight is more in male, height is more in male, BMI is more in female, and others is same in both. So start. Age 19 to 39 years. 19 to 39 years. You can say 20 to 40 also if you wish. Okay. This is regarding the age. Now coming on the weight. Here it is 65 kg. Here it's 55 kg. Okay. Coming on the Height, here it's 177 centimeter or 1.77 meter. Here it's 1.62 meters. Okay, coming on the BMI. BMI is more in female. Both of them are 20 point, but this is 20.75, this is 20.95. Others may, both of them should be free of disease, though both should be active for the work, 8 hours of work, 8 hours of sleep, and 2 hours of recreation. We are done. Okay, this is reference Indian male and female. Please learn the definition. You have to learn that. Okay, protein requirement we have already seen. We are done with the calorie. Now coming on the protein requirement. I already taught you the protein requirement, I guess. Protein requirement for a male, protein requirement for a male, for a non-pregnant female, for a pregnant female, and for a lactating female. Okay, 3 type of female. All male require 54 gram of protein per day. Whether the male is sedentary or moderate or intense worker, it doesn't depend on activity. All male, whether sedentary male, moderate working male, or intensely working male, they all require 54 grams per day. All female requires 46 grams per day. During first trimester, nothing additional is required. During second trimester, 46 plus 9.5. During third trimester, 46 plus 22. 46 plus 22, whatever is the answer. 46 plus 22, whatever is the answer. Okay, during lactation, during first 6 months of lactation, 46 plus 17. During next 6 months of lactation, 46 plus 13. So you get questions on all these. You have to learn. We have already discussed it in the obstetric, preventive obstetric. That's why I'm not insisting to learn. Okay, protein requirement. Now this is the protein content of various food item. You can see among the vegetarians, maximum protein is present in the soya bean. So if you eat 100 gram of soya bean is a type of pulse. Okay. So if you eat 100 grams of soya bean, in the 100 gram of the soya bean, 43 gram is protein. 43 grams is protein. Other pulses, 100 gram of other pulses have only 25 grams of protein. Fish, 100 gram of, this is all 100 gram. 100 gram of fish is having only 21 gram of protein. So don't learn the values, learn soya bean is having highest protein. You get question on that. Now in the protein is made up of amino acid. You get questions on the amino acid. There are 5 type of amino acid. Let me tell you the 5 type of amino acid. Can I tell you the 5 type of amino acid? Listen, there are 5 type of amino acid: essential amino acid, non-essential amino acid, semi-essential amino acid, conditionally essential amino acid, and limiting amino acids. Let me tell you the meaning of each of them. The 5 type of amino acids. Okay, you get many questions out of them. So protein is made up of amino acid. What is essential? As the name indicate, essential means they are essential for diet. We have to eat them in the diet because they are essential in diet. Essential matlab they are essential in diet. We have to eat them daily. They are not synthesized in the body. That's why they are essential. Non-essential is reverse. We don't have to eat them in diet. They are non-essential. Don't eat them in diet. Don't bother because body itself synthesizes them. So the body do not synthesize. We have to take in diet. They are essential. And the one which are synthesized in the body, we don't have to take in diet. They are non-essential. First you understand that. Let me give you the example of these two. Then I will come on semi-essential and conditionally essential. I will come on that. So what is essential? I told you we have to take them in the diet because body do not synthesize them. We have to eat them daily. We have to supplement in our food every day. So how many amino acids are there? 10. 10 amino acids are essential. Learn their names. 10 amino acids. There is a mnemonic. Mnemonic is private Tim Hall. How we write the private? PVT. PVT is private. PVT Tim Hall. HALL Hall. So count, they are 10 in number. You can count. They are 10 in number. It's very easy. So P stand for phenylalanine. V stand for valine. But 2 T's are there. One is threonine, one is tryptophan. Threonine and tryptophan. I is isoleucine. M is methionine. H is histidine. A is arginine. And 2L is leucine and lysine. Leucine and lysine. It's very easy. PVT. Okay. Tim. HALL Hall. Say the full form. Phenylalanine, valine, threonine and tryptophan. Okay. Isoleucine, methionine, histidine, arginine, leucine, lysine. So these are the 10 amino acids you can see. Okay, the 10 amino acids are in front of you. These all are 10 amino acids. Just a second. Okay. So these all are essential. You have to take them in your diet daily. Make sure your diet contain all 10 daily because they are not synthesized in the body. You have to take them. That's why they are essential for you. You have to eat them daily. What are non-essential? You don't have to take them in the diet and body synthesize them. You don't take them in the diet. They are non-essential for you. So don't learn their list. Remaining all. So except the PVT Tim Hall, whatever is pending is non-essential. I don't recommend you to learn the list. So it can be alanine, arginine, asparagine, aspartate, cysteine, glutamic, glycine, ornithine, proline, serine, tyrosine. So these are not coming in PVT Tim Hall. Except PVT Tim Hall, all are coming here. Please learn like that. Now what is semi-essential? We have learned essential. We have learned non-essential. But what is the semi? Semi मतलब आधा आधा. Semi essential क्या है? They are essential for children but not essential for adults. That's why semi. Semi यानी half half. Semi essential. They are required only in children but they are not required in. So children should eat them in diet. They are essential for them but adults should not eat them. Body will take care of them. Okay, it is synthesized in the body. So they are semi essential. Two of them are semi essential. The mnemonic is HA. Histidine and arginine. Histidine and arginine. H and A, histidine and arginine. The next is conditionally essential. So we have seen essential. Essential are those which are required in diet. Non-essential, they are those which are not required in diet. Semi-essential, they are essential for children but not for adults. But what is conditionally essential? What do you mean by conditionally essential? Conditionally essential means actually they are non-essential only. They are non-essential only. But they become essential if their precursors are absent. They convert into essential. That's why they are conditionally essential. वैसे तो ये non-essential हैं, but they become essential if their precursors are absent. So they are non-essential, but they become essential if their precursors are absent. So they are two. The mnemonic is CT, cysteine and tyrosine. Cysteine and tyrosine, CT. They are two in number, CT. Okay, okay. CT, cysteine and tyrosine. And last one is limiting amino acid. The last one is limiting amino acid. What do you mean by limiting amino acid? One particular food is limiting in one amino acid. That is limiting amino acid of that food. Like all cereals are limiting in threonine. What do you mean by cereals? Cereals contain three things. The rice and wheat. Okay, rice and wheat is coming in the cereals. So rice and wheat don't have threonine. Okay. Pulses, all the pulses are deficient in methionine. They don't have methionine. And maize yani bhutta. You know maize. Maize is there. Corn, maize. Maize is deficient in tryptophan. Okay, I will tell you a way to learn that, but please learn. The maize is deficient in tryptophan. That's why from our childhood, my mother asked me to mix dal chawal and eat it. You know, favorite Indian food, dal chawal. Do you eat dal chawal? One of the favorite recipe we eat in India. The rice and the pulses. We mix the dal and chawal. Why? It is known as complementary food. The rice is deficient in threonine. The pulse is deficient in methionine. If you mix the two, they complement each other. They complement. That's why we try to mix the food. We do not eat only rice. We do not eat only pulse. We do not eat only dal. We mix them. That is complementary food because they supplement each other. You got my point? Now, how to learn which is deficient in what? How to learn? Pulses ke liye there is no mnemonic. You have to learn Prime Minister, PM. Pulses is deficient in methionine, PM. Pulses is deficient in methionine, Prime Minister. Pulses deficient in methionine. You have to learn that. Now, when you eat the cereals in your lunch. Huh? You eat cereals in your lunch. You eat rice and wheat. No? What do you eat in your lunch? Either rice or wheat. Wheat means roti, chapati. And you eat in the dinner. When you have lunch, 3 o'clock. When you have dinner, 9 o'clock. So 3 and 9, 309. This is how I can learn. Okay. 3, one of the student only told me. 309. 309. 3 and 9. We eat cereals at 3 and 9. So cereals are deficient in 309. You will never forget now. You will never forget. We eat cereals in lunch and dinner. We have lunch, dinner at 3 o'clock and 9 o'clock. So 309. 309. So cereals are deficient in 309. You can learn like that. Cereals are deficient in 309. Prime Minister. Pulses are deficient in methionine. And last is maize. Maize ki ट्राली है ट्रिप्टोफान. You can learn like that है ना. मेज भुट्टे की ट्राली है. So tryptophan. Maize is deficient in tryptophan. So please learn the three things. Okay, got it? Cereals, pulses, and maize. Can you tell me what they are deficient in? Cereals. When we eat cereals, 309. So 309. They are deficient in 309. Cereals. Pulses, Prime Minister. Okay. Minister is methionine. And maize is tryptophan. Tryptophan. You can learn, or you can make some other mnemonic. Tryptophan. Okay, so maize. So please learn. You get questions on that. Okay, so what we have learned the amino acid topic. There are 5 types of amino acid. Can you tell me what are the 5 types of amino acid? Please tell me. Essential amino acid, non-essential amino acid, semi-essential amino acid, conditionally essential amino acid, and limiting amino acid. Tell me the definition and example of each of them. You get many questions on that. Essential are essential in their diet. In our diet, we should eat them because body do not synthesize them. Non-essential, we should not eat in our diet because body synthesize them. Okay, semi-essential are essential for children. Okay, but not essential for adults. That's why they are semi. They are not essential for adults. Okay, conditionally essential, they are actually non-essential, but they convert into essential if their precursors are missing, and limiting amino acids are absent in a particular food item. Now we will see the examples of each of them quickly. So essential amino acid, there are 10 amino acids. The mnemonic is PVT, TIM, Hall, PVT, TIM, Hall. Okay, HALL, Hall. Total 10 are there. The remaining all will fall in non-essential. Don't learn the list. Remaining all will fall here. Semi-essential are only 2, arginine and histidine. Conditionally essential are 2, cysteine and threonine. So please learn cysteine and tyrosine, histidine and arginine. And limiting, you have to learn the limiting in 3 food items. The limiting amino acid you have to learn in 3 food items. The limiting in cereals, the limiting in pulses, and the limiting in maize. I told you how to learn. So cereals mein it's threonine, pulses mein it's methionine, maize mein tryptophan. Without any confusion, please learn it. You get questions on that. So this is all about the various types of the amino acid. Okay, now the next topic we are taking is the fats. The next topic we are taking here is the fats. Let's talk about the fats. Okay, there are 2 types of fats, saturated fatty acids and unsaturated fatty acids. Fats are organic compounds. What do you mean by organic compound? They are made up of carbon. So what do you mean by saturated and unsaturated? The valency of the carbon is 4. I guess everyone know. The valency of the carbon is 4. So there are 2 types of fatty acids, saturated fatty acid and unsaturated fatty acid. In saturated fatty acid, the carbon is saturated. It's saturated, no double bond. In unsaturated fatty acid, it is having multiple double bonds. Maybe 1, 2, 3, not constantly, maybe irregularly, double bonds are there. This is unsaturated. So which one is good? Saturated good or unsaturated good? So unsaturated are good. For our health, we should eat unsaturated fatty acid. We should not eat the saturated one. Saturated one are not good for our heart, for our health. Okay, it is causing the coronary artery disease. Okay, saturated fatty acids are not good. Unsaturated are further of 2 types. It can be mono unsaturated fatty acid, MUFA, or polyunsaturated fatty acid, that is PUFA. In mono unsaturated fatty acid, only 1 double bond is there. And in polyunsaturated fatty acid, multiple double bonds are there. You are getting my point. In mono unsaturated fatty acid, only 1 double bond is there. In polyunsaturated fatty acid, multiple double bonds are there. That is mono and the polyunsaturated fatty acid. Got my point? So first of all, you see the fatty acids are of 2 types. There is saturated and unsaturated. Unsaturated are further of 2 types. Mono unsaturated, 1 double bond is there. Okay, and polyunsaturated, multiple double bonds are there. If multiple double bonds are there, where is the first double bond? The first double bond is on the carbon number 3, it's omega 3. The first double bond is on the carbon number 6, it's omega 6. And the first double bond is carbon number 9, it's omega 9. So we have 3 types of PUFA, omega 3, omega 6, and omega 9. I hope you are getting it. Yes. So that is the types of the PUFA. The 3 types of the PUFA is there. Okay, the 3 types of the PUFA is there. So we will talk about them one by one. Let's talk about the saturated fatty acid. Saturated fatty acid don't have any double bond. They are saturated. Example, palmitic acid, uric acid, stearic acid. They are not good for health. Don't eat them, please. They are very cheap, but you eat all the samosa kachori in the market, they are available, so they all are there in the saturated fatty acid. Don't eat them, they are not good for health. The unsaturated fatty acid, they have double bonds, they have 1 or more. If they have 1 double bond, it's MUFA. If they have multiple double bonds, it's PUFA. PUFA are good. Okay, PUFA have more than 1 double bond. But where is the first bond? The first bond is on the carbon 3, it's omega 3. The first bond is at the carbon 6, it's omega 6. And the first bond is at omega 9. Okay, omega 3 and 6 are important. Omega 3 may learn 3 examples. Omega 3, it's alpha linolenic acid, icosa pentathonic acid, and docosa you can see docosa hexoenoic acid. Docosa hexoenoic acid, DHA. So EPA and DHA you can say. So alpha linolenic acid, EPA and DHA, these 3 are omega 3. Omega 6 may also, you have 3 examples. This is linolenic acid. This is gamma linolenic acid. This is, you can see, alpha linolenic. This is gamma linolenic. And this is linoleic acid and arachidonic acid. You have to learn the examples. Okay, that's it. That's it. Now, the next thing, if the essential fatty acids are missing in the diet, there is a disease. The disease is known as phrenoderma. What do you mean by phrenoderma? In the phrenoderma, the skin become like the toad. Can you see the toad? Toad is the frog. The skin become like the frog. Can you see the frog skin? It's granular. The skin become the granular. The skin become the granular like the frog. Can you see the skin? The skin becomes granular like the frog. It's the frog skin. The name of the disease is the phrenoderma. It is more common in Kerala, Karnataka, and Gujarat. It is due to deficiency of essential fatty acid. It's also a one-liner question in your exam. The next thing I will like to teach you 2 minerals on which frequently question come in your exam: iodine and fluorine. iodine and fluorine you get frequently. Fluorine mein Nalgonda technique is very important, and in iodine few points are important. So we will see two important minerals here. Iodine is mainly present in the seafood. It is mainly present in the seafood. You can see the most common source is the seafood. Requirement 150 microgram per day. Nobody is going to ask you, but for your knowledge, you should know 150 microgram per day. It is mainly present in the seafood. Iodine. Okay. Iodine deficiency disorder are known as IDD. If iodine is not adequate in the diet, iodine deficiency disorders can occur. Iodine deficiency disorder, these are the symptoms. Okay. So iodine deficiency disorder, what are the symptoms? It depends in which age group it is affecting. Is it affecting fetus? Is it affecting a neonate? Is it affecting a child, or is it affecting an adult? The symptoms are different. In a fetus, abortions will occur, stillbirth will occur. You can see abortions and stillbirth will occur if it occurs in a fetus. Okay, and stillbirths will occur. Abortion, stillbirth will occur in a fetus. In neonate, infant mortality will be there. The infant neonate will die, and endemic cretinism will be there. Can you see? Endemic cretinism will be there. You know, the height is less and endemic cretinism is there. In children, subnormal mentation, IQ will be less. Subnormal mentation will be there, and delayed development will be there. And in adults, it will be goiter. So symptoms are different. It is known as iodine deficiency disorder. In fetus, abortion and stillbirths are there. In a newborn, it can be cretinism. Okay. In a child, it is delayed development and delayed mentation. You know, IQ will be less, and in an adult it can be goiter. It is iodine deficiency disorder. So how to prevent it? We all do not eat the seafood. The best source is the seafood, but we do not eat the seafood. So the second source, we get it from the soil. But whenever the people is living on an altitude, imagine someone is living in a hilly area, altitude. Someone living in the plains, the soil contain the iodine. So whatever food we are getting, it is properly iodized. But someone who is living on the altitude, on a hilly area, here the soil do not have the iodine, so they can have the iodine deficiency disorder. We do not want that. So we want to do the fortification. We want to provide them iodine in some other source. So we will do the fortification of salt. We will do fortification. We will mix iodine in the salt. Why we have selected only salt? We have not selected anything else for the fortification, because salt is something that is eaten by everyone. Whether the person is rich, whether the person is poor, whether the person is any religion, any country, everyone eats salt. So salt is something that everyone eats, and it's cheap also. So we have selected salt as a vehicle via which we can provide iodine also to the people. So we should eat iodized salt. Any brand. I'm not promoting any particular brand, because many brands are available nowadays which are providing iodized salt. So we should eat the iodized salt. So what are the criteria? So how much iodine should be mixed in the salt? How much iodine? At the point of the production, it should be more than 30 ppm, parts per million. ppm is parts per million. It should be more than 30 parts per million. This is the criteria at the point of the production, wherever the production of the salt is taking place. After that, just suppose this is the production is done. Now after many months, some consumer have taken and utilizing it. So during these months, the iodine concentration will fall. So at the time of the consumer level, it should be at least 15 ppm. So at the point of the production, it should be 30 ppm, and at the point of the consumer, it should be at least 15 ppm, and it should be mixed in the form of potassium iodide. Potassium iodide is mixed in the form of the potassium iodide. We are fortifying the salt in the form of the potassium iodide. Okay. Iodized oil. The second option. The first option is the salt. Eat salt which is iodized daily, or you can use iodized oil is available. You have to take the intramuscular injection once every 4 years. Every 4 years only once. If you don't want to eat iodized salt, it's okay. You can take one injection every 4 years. That is of iodized oil. This poppy seed oil is available, that is fortified with the iodized oil. So injection has to be taken. Intramuscular injection every 4 years, one injection. So iodized salt is available. Iodized oil is available, but nowadays we are using double fortified salt. In the salt itself, we are mixing two things. One is iodine, second is iron. Because we realized in India, anemia is also very common. So in the salt, we can give two things to the people. Number one, iodine. Number two, iron. So such a salt which contain both the things. It is known as double fortified salt, or also known as twin fortified salt. Two things are fortified here, iodine and iron. How much iodine? How much iron? So 1 gram contain 40 microgram of iodine, and 1 gram contain 1 milligram of iron. So 40 microgram and 1 milligram is present in 1 gram of the salt. 1 gram of salt. You are getting my point? So we are taking salt and we are mixing two things in the salt. Salt is NaCl. We all know salt is NaCl. We are mixing two things in the salt. Number one, iodine. Number two, iron. We are doing double fortification. So such a salt is known as double fortified salt or twin fortified salt. So how much iodine or iron is present? Iodine is 40 microgram and iron is 1 milligram in 1 gram of the salt. 1 gram of the salt. I hope you are getting it. So this is double fortified salt. So that's the thing. Got my point? So IDD, iodine deficiency disorder, we can prevent by 3 methods. Either fortified salt or double fortified salt or iodized oil. These are the 3 methods by which we can prevent the IDD. IDD, Global IDD Day is celebrated on 21st October every year. If iodine deficiency is there, IQ is reduced by 13 points. The person have mental retardation. IQ reduced by 13 points. So that is the thing. The last thing I am teaching you here is the fluorine in the minerals. I want to teach you 2 minerals. Iodine is done. Now I'm teaching you the fluorine. Fluorine. Okay. The normal range of fluorine is 0.5 to 0.8 milligram per liter. This is the norm. It's very narrow. It's very narrow. 0.5 to 0.8 milligram of fluorine. It is the recommended level. It is present in the drinking water. Do you drink water? So water contains fluorine. How much water fluorine should be present in the water? It should be 0.5 to 0.8 milligram per liter of water or parts per million. 0.5 to 0.8, because less than 0.5 it will cause deficiency disease, and more than 0.8, especially more than 1.5, it will cause excess wala disease. So it is a double-edged sword. कम है तो भी problem है, ज़्यादा है तो भी problem है. So fluorine is a double-edged sword. Double-edged sword. You know the meaning of the double-edged sword? दो धारी तलवार, है ना? कम है तो भी problem, ज़्यादा है तो भी problem. So you have to take fluorine in this recommended level only. 0.5 to 0.8. Because if it is less than 0.5, it causes disease. The name of the disease is dental caries. If it is less than 0.5, 0.5 milligram per liter, it causes dental caries. Number one. And if it is more than 0.8, especially more than 1.5, more than point, it causes a disease known as fluorosis, which is of 3 types. Fluorosis is of 3 types: dental fluorosis, skeletal fluorosis, and genovulgum. Let me explain. What is dental fluorosis? In dental fluorosis, if fluorine is an axis, if the fluorine is more than 1.5, it is 1.5 milligram per liter, it causes molting. It causes mottling of the teeth. Mottling especially of the upper incisor. Mottling of the teeth, especially of the upper incisor, the permanent teeth. Okay. So mottling of the teeth taken place at 1.5 milligram per liter. Okay, if it is 3 milligram per liter, it causes skeletal fluorosis. 3 to 6 milligram, it causes skeletal fluorosis, in which the cripping can also occur. More than 10, it will cause genovulgum. It can cause genovulgum. You got my point? So what I told you fluorine. What is the recommended level of fluorine? It's 0.5 to 0.8 milligram per liter or ppm. It's a double-edged sword. If it is less than 0.5, it's a problem. If it is more than 0.8, it's a problem. Double-edged sword. If it is less than 0.5, the name of the disease is only one: dental fluorosis. Dental caries. Dental caries. And I have shown you the image, dental caries. But if it is more than 0.8, there are 3 possibilities. 1, 2, 3. It can lead to dental fluorosis. This is dental caries. This one is dental fluorosis. Dental fluorosis. It can lead to skeletal fluorosis, and it can lead to genovulgum. They all are more than 0.8. So if it is 1.5 milligram, it's dental fluorosis. It's 3 to 6 milligram, it's skeletal fluorosis. And more than 10 milligram, it's genovulgum. So I have shown you the images. Here mottling of the teeth takes place. Here dental में caries होंगे. यहाँ पे mottling होगा. Yellow colored teeth, incisors, upper incisors. Here skeletal fluorosis, in which crippling will take place, and genovulgum will take place at more than 10 milligram per. So what intervention have to be taken? If it is less, it has to be given. So give it in the form of the toothpaste. So whatever toothpaste you use, maybe it is fluorinated. It contains the fluorine to prevent you the deficiency. If it is less, give it in the form of additional in the form of toothpaste. And if it is more, you have to remove it. You have to do defluorination of water. So suppose my water contain more fluorine, I have to do defluorination, then I have to use it. So defluorination is done with the help of a technique that is Nalgonda technique. So Nalgonda technique is for excess fluorine. To remove the excess fluorine, we use defluorination. Defluorination is done by Nalgonda technique. If it is less, we just give the toothpaste in the form of the toothpaste. If it is more, we have to remove it. Removal is done by Nalgonda technique. You got my point? So interventions. If it is less, give it in the form of the toothpaste. And if it is more, do Nalgonda technique. Nalgonda technique is discovered by NERI. What is NERI? National Environmental Engineering Research Institute, Nagpur. It is in Nagpur. NERI, Nagpur. It's a question. Here, defluorination is done. How defluorination is done? How? If the water contain excess fluorine, how I can remove that? 6 steps has to be followed. 6 steps in a sequence. First, add lime in the water. Then add alum, and then add bleaching powder. So learn the sequence lab, L-A-B, lab. Lime, alum, bleaching powder. First add lime, followed by alum, followed by bleaching powder. So the fluorine will make complexes with that. After that, do the flocculation, sedimentation, and filtration. So learn the mnemonic LAB, FSF. So learn the mnemonic, 6 steps. So you can see, first of all, in the water, we are adding the lime. Then we are adding the alum. Okay, and bleaching powder is not shown here. Then we are adding the bleaching powder. After that, we are doing flocculation, then sedimentation, then filtration, FSF. And finally, the fluorine is removed from the water. So what are the 6 steps in Nalgonda technique? What is Nalgonda technique? Nalgonda. What is Nalgonda technique? Say removal of fluorine from the water, defluorination. What are the 6 steps? The 6th step is LAB, FSF. So what is LAB? 3 things we have to add: lime, alum, and bleaching powder. And 3 process we have to do: flocculation, sedimentation, filtration. So learn the sequence, you get question on this. So this is all about fluorine. How many of you got it? So let me summarize the fluorine. I taught you iodine and fluorine. The recommended level of fluorine is 0.5 to 0.8 milligram per liter in drinking water. It's a very narrow range. Less than 0.5, it causes the disease. More than 0.8, it causes the disease. Less than 0.5, it causes dental caries. Okay, and more than 0.8, it causes 3 diseases: dental fluorosis, skeletal fluorosis, and genuvalgum. Okay, so here we do intervention as toothpaste, and here we do intervention as defluorination. Defluorination is done in the form of the Nalgonda technique. Nalgonda, which is discovered by NERI, Nagpur. Here we do the 6 steps. What are the 6 steps? We add lime, alum, bleaching powder, LAB, and we do 3 things: flocculation, sedimentation, filtration. That's all about it. That's all about it. That is all about fluorine. And you get many questions on the Nalgonda technique and many things about the fluorine. Okay, anyone have any confusion? Now, many things are still pending. You know, many other topics I still require many hours to complete the entire high yielding points of the PSM, because PSM is a very big subject, you know, and you get nearly 30 to 35 questions in your exam from this subject. You know, it's a very vast subject, but try to cover all those topics which are very high yielding, and you are definitely going to get questions from today's session in your exam. Okay, so we will try to schedule more session. If you want more session, kindly write down in the chat box and the comment box. If you want more session, I will ask the team to give me more session here, and we will conduct more session. And the remaining portions, now the epidemiology is remaining, epidemiology and epidemiological studies, communicable disease, non-communicable disease, and some small chapters like biomedical waste management, genetics, mental health, and some small chapters are there, you know. Okay, all these small chapters we combine at a one. These are the main topics which are still remaining, and we can cover it. So how was today's session? Was it useful? Was it useful or not? You find it useful? Today's session, how was it? You gained it? You learned something? Yes or no? I think it was useful. So thank you so much. I would like to wish best of luck to all of you for your exam. I don't know whether we meet again or not. So best of luck for your exam. Wishing you the best, and give your best shot in this exam only. Whatever exam you are targeting, maybe most of you are targeting your FMG. So please give your best shot this year only. I do not want to see these faces again in the next batch. Okay. And once you got selected, don't forget to inform anyone in the team or to me. And thank you so much. Okay. Thank you for your precious time, your attention. Bye-bye. Hopefully this